Yeah. Good morning, everyone. Good morning, Dr. Sushma.
Good morning, madam. Nice to have you here with us.
Thank you. Thank you for inviting us for the panel discussion.
Thank you, ma'am.
Good morning.
Good morning, everyone. So we have started the live streaming and we can start the program now. We are once again a warm welcome to everyone from the Society of Maternal Fetal Medicine Mysuru chapter. And I would now request our president, Dr. Sushma Dev, to welcome the audience.
Very good morning, everyone. On this shining Sunday morning, I welcome all the faculties and delegates for joining us on this virtual webinar series organized by the Society of Maternal Fetal Medicine India Mysuru chapter on cardiac obstetrics. We are proud to announce that this is our third webinar series on cardiac obstetrics, and today we are focusing in the cardiac crisis in obstetrics, that is the emergent conditions of cardiac diseases, which are often nightmare to most of the gynecologists, wherein we are feared of the significant maternal mortality, and many a times it is out of our hand when we receive these women in labor or in emergent situations. And we all know that for the best management of high-risk obstetrics, the cornerstone is multidisciplinary management with the ultimate goal of reducing the maternal mortality rate all across the globe. We are overwhelmed by the significant scientific support offered by our eminent specialties of cardiologists all across the country, and of course, our team of anesthesiologists, the professors and eminent people, and also the physicians who have been part of this webinar series. And the motto of our Society of SMFMI is that we are bringing in together the different teams, different specialties, so that we can club in our knowledge and we can execute the maternal obstetric management in the best possible way. And we will reduce the MMR in India to the most expected and to the least levels. Today, we are focusing on the emergent conditions, that is the PPCM, the MI, and arrhythmias, which are very important, often unspoken and often not discussed topic. And I'm sure our team of cardiologists and senior obstetricians will throw significant light and bring in a lot of knowledge in the management of these crisis situations. And today, we are very fortunate that we have our eminent faculties. I'm glad to, and it's an honor to welcome Dr. Charmila Ayovu, Madam, who is our Vice President, Foxy, South Zone. And Madam has been a driving force and a mentor and helping us and guiding us in especially the conference handling. And also Madam is our mentor in organizing the Foxy South Zone Conference, which is going to be held in Mysuru. And this is a proud moment for the Karnataka, and we are proud to have Madam with us. And it is my proud privilege to welcome our another eminent faculty, Dr. Kasturi Donimat Madam, who is the former president of KASOGA, the Karnataka Federation of Obs and Gynac. Madam is the former head of the Department of Hubli Medical College, and also the former the president of Hubli Dharwad Society. Madam has always been a point of pioneer, and also as a team of Karnataka, she's always there with us, and at any point of time, she's always there to advise us and give us maximum inputs with the best execution of any scientific events which we plan. And of course, we have our team of eminent cardiologists who have joined us across Mysuru, across Karnataka, and of course, South India as well. I'm very happy to welcome Dr. Sunil Kumar, Dr. Manjappa, Dr. Keshav Murthy, Dr. Annie Princely, and our own Dr. Pushpalata from the team of obstetricians, Dr. Yatish. And also, it's my privilege to welcome our other faculties, Dr. Ashish, Dr. Balraj, Dr. Sridevi Mechkud, Dr. Vijayalakshmi ma'am. She is the professor of anesthesiologist, MMCRI, Mysore, and she's a president of intensive care unit of Mysore chapter, and my good friend, Dr. Prasila Thomas from Hubli. Dear friends and delegates, This program, our webinar, will definitely throw a larger light and help us out in managing our pregnant women in a better care. I welcome each and every faculty and, of course, our delegates, and most importantly, our postgraduates who are being enlightened in this special unit of cardiac care in obstetrics. I take this opportunity to welcome each and everyone from our Society of Maternal Fetal Medicine, wherein we are doing significant efforts in managing and enlightening our knowledge on medical disorders in pregnancy. Thank you, everyone, and kindly enlighten us with this webinar series. Thank you. Over to Hemapriya. You're muted.
Thank you, Sushma. Let us now start the program with the lamp lighting. Mahima. Thank you, Mahima. Now, I would request Dr. Sushma to introduce our chief guest. And
Can we have CV of ma'am, please? Of course, once again, it's my privilege to welcome our chief guest, our eminent Dr. Charmila Ayovu, ma'am. Ma'am is very well-known Foxian, and madam is doing a significant work in the field of obstetrics and gynec, and she's currently the vice president of Foxy South Zone, and she's the president of Trichy OBG Society, and she's the chairperson of Clinical Research Committee Foxy, and also she's a national coordinator and UNICEF Foxy PCA and MEDA Foxy PG program, and also she's been the series convener of ICOG Journal Club and WHO Southeast Asian Region Indian member, and is the president of Menstrual Hygiene Management Consortium, and she's the secretary of Gestosis India currently, and of course the MC Managing Committee member of PCO Society of India. We are really fortunate for accepting to be the chief guest of today's VLS series, ma'am. And over to you, ma'am, for your address.
Thank you, Sushma. It's an honor to be in a program where such meticulous planning is being done by the organizing committee, and I'm seeing Dr. Hemapriya constantly giving the updates regarding the webinar, and it is always it's a pleasure to see such webinars being conducted. And I would like to thank Dr. Sushma, the president, Dr. Hemapriya, the secretary, and Dr. Sweta, the treasurer, for the opportunity. And Dr. Prakash Mehta sir is known for his academics, and doing a program under his guidance is something which many of us look forward to. And I'd also like to welcome the executive committee of the association, and a beautiful curating of topics. Like I've conducted almost like, I think, 1,000 webinars in the since COVID. And I'm considered as a webinar queen or something, because I keep on doing webinars, but it's very difficult to see odd topics, because always you see the same PPH, so the same PIH, the same induction of labor and all that, but seeing such wonderful topics which are quite new and dealing, and we see that quite often now, ischemic disease in pregnancy, it was never seen earlier, myocardial infarctions, patients conceiving with pacemaker in situ, and arrhythmias in pregnancy, all very, very, very different topics. And I know it takes lots of effort to get such eminent faculty to talk on such difficult subjects. And it's my honor to attend a program where Dr. Sunil Kumar, Dr. Manjappa, Dr. Atish, Dr. Shweta Naik, and Dr. Annie Princey are the faculty. And I'm looking forward to listening to the program, because this we are dealing with day in and day out nowadays, which was not seen so earlier when we started practicing obstetrics. like to wish Sushma all the best. She's doing a wonderful job preparing for UA Foxy, and I know it's so difficult because we are going ahead with the Vice President's Conference this weekend, and it's an extremely difficult job because we are not getting that support which we were getting in earlier years, and it's actually an uphill task. And I'm seeing Sushma doing it with so much of enthusiasm and courage, I will say. I'd like to wish the entire team all the best for the conference as well as for this webinar. Thank you, Dr. Himapriya, for all that coordination you did. Thank you so much for the opportunity.
Thank you, ma'am. Thank you.
Thank you so much, ma'am, for such a wonderful, supportive, and you have always been with us. And it's a pleasure to have you with us. We request you to kindly stay with us till the end of webinar and give your updates in amidst our scientific sessions. Thank you so much. And it's again my honor, privilege to invite and introduce our own Kasturi Donimat ma'am, who is the eminent faculty and dear of all OBGYNs of Karnataka. She's well known, she's often known, and always with her smile and the temper, the kind of comfort she gives us whenever we approach her for any of our problems related to our scientific discussion. Madam is always there with us. It's a honor to have Kasturi ma'am with us. She is the immediate past president of Karnataka Federation of OBGYN Karnataka and immediate past head of the department of KIMS Hubli and ex-professor in KIMS and the past president of Hubli Darbar Society. She is the principal investigator of many international research projects and MCHA inspector. And Madam is well known for conducting the Gnana Harsha, the PG training program, wherein thousands of postgraduates attend for the orientations and learning of the exam-oriented topics and CMEs. And Madam has conducted the Karnataka state conferences and many CMEs. Madam is the very eminent faculty when it comes to Karnataka, and we are fortunate that Madam has agreed to accept our invite as a guest of honor. We thank you from the Society of Maternal Fetal Medicine India, and over to you, ma'am, for your address. Kasturi, ma'am.
Thank you so much, Sushma. Yeah, I'm audible?
Yeah, ma'am.
Yeah. Ellargu namaskara. Very pleasant morning to one and all, and very beautiful weather here. And first of all, I thank Dr. Very active, very dedicated and hardworking personality, Sushma, for giving me this opportunity. She's taken this Society of Maternal Fetal Medicine of Mysuru chapter very high because it's so active. I've seen so many chapters, but this Mysuru chapter is like so actively doing so much work under the guidance of Dr. Sushma and Dr. Himapriya for your coordination. I thank Dr. Hema also. And first of all, thanks to Dr. Charmila Madam for being the chief guest, and very happy to hear the beautiful words from you, Madam, and looking forward to meet you at SouthCon this weekend. And I'm sure you're so busy, in spite of a busy schedule, you made time for this program. Thank you, Madam, Dr. Charmila. Then today's topic, cardio obstetrics, very, very important topic. Sushma has selected very excellent topic. Like congenital heart disease, etc. They have also are on an increasing trend. Earlier, one case here, there everybody used to go and auscultate and try to listen. But so many cases of pre-existing, more than the pre-existing, the new cardiac problems during pregnancy are a real threat. She was normal, and during pregnancy, she developed so many cardiac problems. And especially what we have seen, a tremendous increase is PPCM cases. Peripartum cardiomyopathy, we have seen a lot. I don't know, we'll ask the opinion of all the eminent figures. Especially, we suddenly saw a rise immediately after COVID, you know. Post-COVID, so we had in a ICU, in our OICU, 6-7 cases of PPCM. Earlier, if you get one case, all of us used to go there and try to see one case, how is it? But now so many cases, and that too so much of that ejection fraction, 30%, 30% and all. So I'm looking forward to listen to all the eminent faculty today, and it will be great learning from them. And very important topics selected by Sushma, and very eminent faculty are selected. I think it's really going to benefit all the gynecologists who have joined and all the postgraduates who you get, and especially again the unexplained cardiac failures also we are seeing a lot nowadays, and then arrhythmias, sudden arrhythmias also, so much of changes even intra-op and post-op. So after listening to all the eminent faculty, we'll be more confident to handle these cases. Thank you, Sushma, for taking up this topic and selecting such eminent faculty and the topics for this webinar. It's really going to make a difference in the practice of everybody. Thank you once again for inviting me as guest of honor, and looking forward to learn from you. Thank you.
Thank you so much, ma'am, for your wonderful words and words of wisdom. And we request you to stay till the end to give your feedbacks and added information throughout the webinar. And we thank once again all the faculty and welcome everyone. Over to Himapriya for the to start the scientific sessions.
Thank you, Sushma. Thank you, Dr. Charmila ma'am and Dr. Kasturi ma'am for your encouraging words. We shall now move ahead with the scientific sessions. And now I would like to invite our chairpersons, Dr. C.B. Keshamurthy. Dr. Keshamurthy sir is the Chief Consultant Cardiologist at Manipal Hospital, Mysuru. And sir very modestly requested me not to tell anything more about him. A warm welcome to you, sir. And next, I would like to invite my senior, my close friend, Dr. Pushpalata. She is the Professor and Head, Department of OBG at AIIMS Bhopal. Ma'am has worked all the way from Kidwai in Bangalore, and then she has worked on a lot of malignancy projects in AIIMS Delhi. And ma'am also has a keen interest in high-risk obstetrics, and she is the nodal officer for setting up the Center of Excellence in the obstetric HDU and ICU in AIIMS Bhopal. So a warm welcome to you, ma'am.
Thank you.
I would now like ask the chairpersons to take over the session and introduce the speakers.
Good morning, everyone, and thank you for this invitation to participate in this important program. A special thanks to Dr. Hemapriya and the Foxy team for considering us and thinking of us as to be a part of this wonderful program on this Sunday morning. I know you all stress the importance of the cardiac disorders in pregnancy, and it is the same for us also. When we see a pregnant lady or a just delivered lady with a cardiac problem, we also we double in our efforts, because we know there are restrictions in terms of usage of drugs, and these are special clinical situations where we put all our attention, efforts, and knowledge and try to improve them and get them back to their baseline condition and prevent morbidity and any mortality thereof. And we now have a very eminent panel of speakers, and like in the virtual inauguration, we saw that we were led from darkness to light, and this panel of stalwarts will definitely lead us from the darkness of ignorance to the light of knowledge, which we can apply in our day-to-day practice and make our patients' lives better, which is what our life is all about. So we'll start off with the first talk without much ado. Dr. Sunil Kumar, my dear friend from JSS, head of the Department of Cardiology, very accomplished cardiologist in Mysuru. He did his MBBS from AIIMS Belur and then MD medicine from MMC, which is celebrating now the centenary. DM cardiology from Mumbai, from where I did my DM too. So we share some alma maters in the city of Mumbai. He has had tremendous work experience in some of the prominent hospitals of Mysuru and Bangalore, and his areas of interest are adult and pediatric cardiovascular interventions. And I now invite Dr. Sunil Kumar to start off the day with a talk on peripartum cardiomyopathy, which is an extremely important and very current and relevant topic of the day. Dr. Sunil Kumar, please.
Yeah, thank you. So, yeah, my screen is visible.
Yeah, Sunil, you're visible. Yeah.
Yeah.
Just move one slide. Sometimes the slides after sharing, they don't move. Yeah, it's moving. You're fine to go.
And fine then. So respected chief guest, respected guest of honor, respected chairpersons of today's program, Dr. C.B. Keshamurthy, Dr. Pushpalata, and my dear friends and colleagues. At the outset, I would like to thank the Society of Maternal and Fetal Medicine India, Mysuru chapter, and its organizing team for giving me an opportunity to be a part of today's scientific program, and especially this particular program focusing on cardio obstetrics, a virtual program, and looking into the cardiac crisis in pregnancy. I have been given 15 minutes of time to speak about peripartum cardiomyopathy. I'll just give you an overview of peripartum cardiomyopathy because it's a vast topic which is very difficult to be covered in 15 minutes. I think I'll do justice to this particular topic which has been allotted to me. And coming to the introduction of peripartum cardiomyopathy, the heart failure associated with pregnancy and the peripartum period is nothing new. It was recognized as early as in 1800s. The first large case series was published in 1937 in New Orleans. And if you're going to look at the term peripartum cardiomyopathy was coined in 1961. And even though the syndrome was characterized and the terminology was coined, there was no clear-cut definition for PPCM until unless the echocardiography pitched in and the criteria of LV ejection fraction less than 45% was introduced, and that became one of the strong criteria as suggested by NHLBI on a workshop on peripartum cardiomyopathy. Now, coming to the definition of the peripartum cardiomyopathy, it's an idiopathic cardiomyopathy which is related to the pregnancy, usually wherein the patient is going to present with heart failure either towards the end of pregnancy or in the postpartum period. Usually the timelines that is given is in the last month of pregnancy and up to 5 months after the delivery. And very important is these particular patients should not have any other identifiable cause of heart failure, and the LV ejection fraction should be less than 45%. And here very important is the LV may or may not be dilated. So wherein you're going to get an LV dysfunction either with a dilated LV or a non-dilated LV. So these are the three criteria which are to be required for a patient to be diagnosed to have a peripartum cardiomyopathy. Now coming to the incidence, if you want to look at the worldwide incidence, it is somewhere around 1 in 2,000 live births. But if you want to look at across the data from India, the pooled analysis data, the incidence was somewhere around 1 in 1,340 live births. But if you want to look at across, there's a gross variation, especially with respect to various regions, wherein the PPCM could be as high as 1 in 300 births in Haiti or 1 in 100 in parts of Nigeria. And especially in US, the disease is 4 times more common in Black women when compared to white women. Now, etiology, as I said you across, it's an idiopathic cardiomyopathy, which is related to pregnancy or the postpartum period. The etiology is very, very unclear, but there are very well identified risk factors which have been found out for peripartum cardiomyopathy: African descent, advanced maternal age, severe anemia during pregnancy, pregnancy-related hypertension disorders, especially the preeclampsia and eclampsia, multiparity, multiple gestations, obesity, hypertension prior to pregnancy, and prolonged use of tocolytics. So there's a very strong association between these risk factors and the peripartum cardiomyopathy. Now coming to the pathophysiology, because it's an idiopathic, there's no clear-cut etiology, and the risk factors are the only one which has been linked to the PPCM, and as such, the pathophysiology is also multifactorial. So always in the past, it was stressed across saying that the gross hemodynamic changes which are related to the pregnancy could precipitate a peripartum cardiomyopathy. We do know that the hemodynamic changes are of a significant magnitude in the second trimester, but the PPCM is more likely to present in the last 1 month of pregnancy. So that means the hemodynamic changes is definitely not the contributing factors. The second proposed concept was myocarditis, but which was not well proved also. The other one is the toxic hormonal environment, and the increased prolactin levels is one which is pitching around in the corner and trying to prove that that might be the etiology. The other one is a genetic predisposition. The other one is a pro-inflammatory state and an autoimmune state which has been contemplated. But as of now, it is of idiopathic etiology. The pathophysiology is also multifactorial. So wherein we cannot very clearly say that what is responsible for PPCM. But coming to the history and physical examination, what is very important is most of the patients of PPCM going to present in the last month of pregnancy. So if you're going to look at across the presentation, it varies based upon the severity of LV dysfunction. And most of them are going to present with the classical symptoms of heart failure like exertional breathlessness, paroxysmal nocturnal dyspnea, orthopnea, pedal edema. Some patients can present with dry cough, palpitations, lightheadedness, and atypical chest pain. The physical findings could be an elevated JVP or a displaced apical impulse, an audible third heart sound, or a mitral regurgitation murmur. Now, coming to the evaluation, what is very important is most of the symptoms, they do correlate with the pathophysiological changes secondary to pregnancy. Always, there's a tendency to say that this shortness of breath could be related to pregnancy, could be related to anemia. And until unless you have a very high index of suspicion, you are not going to evaluate for peripartum cardiomyopathy. And peripartum cardiomyopathy, as a definition says, it's a diagnosis of exclusion. The moment the patient has a classical symptoms, has got an LV ejection fraction less than 45%, and you cannot explain it with any other possible conditions, you're going to label the patient to have a peripartum cardiomyopathy. You're going to do an initial blood workup, look for the alternate causes for breathlessness or so, like anemia, hypothyroidism, renal dysfunction, liver dysfunction, and BNP, which is a well-proven biomarker for heart failure. Most of the times in ADHF related to peripartum cardiomyopathy, it is elevated. And radiography could be one of the components for initial evaluation to rule out alternate causes for breathlessness. ECG could be normal, could show sinus tachycardia, can have some non-specific changes, intraventricular conduction disturbances, supraventricular arrhythmias or ventricular arrhythmias, or some STT changes. So most of the times it could be non-specific. And we're going to look at across the echocardiography, which is a cornerstone diagnostic modality to diagnose the peripartum cardiomyopathy, where you can assess the LA, the LV systolic function, the mitral regurgitation, the pulmonary artery pressures, and the IVC status. And also you can rule out any other structural heart diseases which might be contributing to the symptoms, which is mimicking a peripartum cardiomyopathy. And again, coming across to the cardiac MRI, especially the plain cardiac MRI without a GAD, so probably helps us in identifying other causes, most commonly the myocarditis, which is related to peripartum cardiomyopathy picture. Now, once you have a high index of suspicion, patients do present to you with symptoms of heart failure, and you do a workup, then we come to the management. So you want to look at across the patient's presentation could be a variable presentation, which is totally dependent on the severity of the LV systolic dysfunction. Some patients can have a mild LV systolic dysfunction with a very mild symptoms. Some patients do present with a florid symptoms and a cardiogenic shock, what we call it to be as a fulminant peripartum cardiomyopathy. So if we're going to look at across the medical therapy of heart failure is well in lines with the guideline-directed medical therapy of heart failure. Here, you need to focus on very important component, that is the pregnancy, or the patient is in the postpartum period, that is in the breastfeeding period. So if we're going to look at across the management of the heart failure during pregnancy, the more emphasis is on beta blockers, especially the cardioselective beta blockers. The second one is the diuretics, very important, the loop diuretics or the cornerstone therapy to make the patient euvolemic. See that you are going to give an appropriate dose, especially to keep the patient euvolemic. Do not dehydrate the patient because it's going to affect the placental perfusion, and hence you have to be very careful with the diuretics. And coming to the digoxin S, you can use it for multiple reasons. And now the present indication is only for patient who has got an LV systolic dysfunction, atrial fibrillation with a fast ventricular rate, just to control the heart rate. And inotropic support in those subset of patients who have got an hemodynamic instability. Now coming across to the pillars of heart failure therapy, what we call it as The RAS inhibitors, the ACE inhibitors, ARBs, and ARNI are the mineralocorticoid receptor antagonists, and the SGLT2 inhibitors, which are considered as the three pillars of heart failure therapy, are absolutely contraindicated in pregnancy. Now, once the patient delivers and gets into the postpartum period, that's the time you can optimize the heart failure medications from ACE inhibitors to spironolactone to beta blockers, diuretics, and SOS need for digoxin. And if you want to look at across, even though ARNI and SGLT2 inhibitors have got a powerful data, so we do not have much data with respect to the lactation and are generally avoided with breastfeeding. And we can use hydrolysine, especially patients who have got LV dysfunction, wherein you cannot use the RAS inhibitors due to their renal pathology or an elevated creatinine or hyperkalemia. So you can always use hydrolysine. And nitroglycerin can be used in acute decompensated heart failure just to reduce the preload and afterload so that the patient is going to get quickly stabilized. And nitroprusside is again contraindicated in pregnancy for the concern of cyanide toxicity. Now, again, coming to the anticoagulation therapy, which is a very controversial area, because we know that the pregnancy is an hypercoagulable state and a patient who lands up with severe LV dysfunction, so they are at high risk for developing an LV thrombus or an LA thrombus. But however, the guidelines are very clear that patients who have got a peripartum cardiomyopathy and atrial fibrillation or a documented LV thrombus on an echocardiography should be anticoagulated. And we all know that the drug of choice is VKA, and you need to time it appropriately, withdraw it just before the delivery, and bridge it with a low molecular heparin, and then switch back to the VKA once the patient is going to deliver. And now, what's the role of ICDs and cardiac resynchronization therapy? Yeah, you need to individualize these particular treatments to the patient, because most of the times, looking at the natural history of peripartum cardiomyopathy, most of these particular patients will show a remarkable recovery. And coming to the mechanical circulatory support, yes, there's definitely has a role to play in fulminant peripartum cardiomyopathy, wherein they have a high chances of recovery, and trying to save the patient during this particular acute crisis, either with an LVADs or an ECMO, is going to definitely help the patient. Now, very important prognostic factors in peripartum cardiomyopathy we look at is any patient who has got an LV systolic dysfunction and doesn't have got an dilated LV tends towards a good prognosis. And even an ejection fraction more than 30% and a fractional shortening on an echo more than 20% at the time of diagnosis goes in the favor of a good prognosis. And one important finding that has been found out is the correlation between preeclampsia and peripartum cardiomyopathy. These patients do wonderfully good in terms of the LV recovery. Absence of troponin elevation is again a good prognostic feature, and absence of an LV thrombosis is again a good feature, because you can see that the patient doesn't land up with thromboembolic events. Coming to the poor prognostic factors, QRS duration more than 120 milliseconds on an ECG, delayed diagnosis, and NYHA class 3 and class 4 has got a worse prognosis, and multiparity and African descent. Now, complications, the maternal could be thromboembolism related to the LV clot, arrhythmias, progressive heart failure, and death. Coming to the fetal complications, which is related to the maternal issue of severe dysfunction and a compromised fetal flow, which results in fetal distress, most commonly resulting from hypoxia. Now, coming to the outcomes, this is one cardiomyopathy which has got a phenomenally good outcomes actually. But however, the clinical outcomes do vary very widely, and most of the patients are going to recover in 3 to 6 months postpartum, but recovery can be found till 48 months of delivery. But if you want to look at the IPAC study, 72% of the patients recovered to LV ejection fraction more than 50% at 12 months. So that means PPCM is one of the good cardiomyopathies grouped under the reversible cardiomyopathy, because most of the patients do a phenomenal recovery, provided they're going to receive the guideline-directed medical therapy. But you want to look at the mortality is anywhere from 4 to 20%, but it all depends upon the patient's presentation, the prognostic factors, and the availability of the level of care to them actually. And very important is the recurrence of peripartum cardiomyopathy in subsequent pregnancies is very high, and the patient should be deferred from becoming a pregnant subsequently, and they should be monitored very closely. Now, coming to the labor and delivery, obstetricians with expertise in the maternal and fetal medicine, anesthesiologists, cardiologists, and specialists in advanced heart failure, it requires a multidisciplinary team to check out the treatment strategy for a patient with PPCM. And most of the times, patients who are hemodynamically stable can be delivered vaginally. Now, we know that these particular patients have a phenomenal chances of recovery towards a normal LV function. And what do we do once these particular patients has been put on a guideline-directed medical therapy and LV systolic function improves or recovers? But we do not have a clear-cut guidelines because there's a very clear-cut entity, something saying that cellular and molecular recovery are going to lag behind the echocardiographic evidence of recovery. Premature withdrawal of medications can precipitate worsening of heart failure, which is well evident in patients with dilated cardiomyopathy, which is of non-pregnancy related etiology. And the reasonable approach is treat the patient for 1 full year, and the patient makes a remarkable recovery, ejection fraction is more than 50%, then start stepping down the therapy sequentially with a long-term clinical and echocardiogram monitoring. Now, to summarize, peripartum cardiomyopathy has become an important cause of maternal morbidity and mortality. The diagnosis of PPCM should be considered in any pregnant or a postpartum woman who has got a symptoms concerning for heart failure. The pathogenesis of this disorder remains completely not understood. Management of peripartum cardiomyopathy largely mirrors the guideline-directed medical treatment for heart failure with reduced ejection fraction, but keep a focus on the pregnancy status and the postpartum period. The timing of delivery and the management requires an interprofessional approach and individualization of the patient. And very important is when you're going to look at the PPCM, there is no disease-specific therapy because we have got bromocriptine, which has been tried out and which is in the phase 3 trials, and the results are yet to be out. The short-term prognosis of patients with peripartum cardiomyopathy is usually favorable, but a subset of patients do not do well and they land up with chronic heart failure. And very little is known about the long-term outcomes of this particular disorder, and hence the particular patient who was diagnosed to have a PPCM should be under long-term surveillance. Thank you for your patient listening.
Essentially, brevity is a true sign of mastery. And thank you, Dr. Sunil, for that wonderful lecture. In 15 minutes, you have given information which is present in several chapters and textbooks on peripartum cardiomyopathy. Thank you for that wonderful talk. And we'll have a discussion at the end with question and answers. Or how do you want it, Dr. Hemapriya? Okay.
Yes.
Yeah.
At the end of the session will be nice.
Okay, that will be a good approach, and we'll have a good interaction at the end. So we'll move on to the next talk by Dr. Manjappa. And like Dr. Sunil highlighted, the thing, it's a multidisciplinary approach, and we have to keep the patient at the center and sit around and have a group kind of approach to this important clinical situation, which is many times critical. Many of the decision makings, especially in the Indian context, where patients are not very, very regular with their follow-up, it becomes an important clinical crisis or a clinical problem. So we have to put our heads together and bail out these patients out of their crisis, applying all the knowledge and information and things that are available to us. Right. I have a great pleasure in now introducing Dr. Manjappa Mahadevappa, who has been my colleague for a few years at Vikram Hospital, and then he moved on to JSS Hospital. He's another eminent cardiologist in Mysuru, very well respected for his work at JSS Hospital along with Dr. Sunil. And he'll now be talking about acute myocardial infarction or ischemic heart disease in pregnancy as a whole. As was highlighted in the introduction, acute myocardial infarctions are extremely rare in the premenopausal age group, but we occasionally see these patients who come in a very critical shape with pregnancy and an acute ischemic event, which is really a crisis for the gynecologist, for the patient, as well as for us. So, Dr. Manjappa, please speak about this topic. You have 15 minutes of your time.
Yeah. Good morning, sir. Are my slides visible?
Yeah,
Yes, yes.
slides are visible. Make it slideshow and move to the next slide.
Yeah. Good morning, all. At the outset, I would like to thank the organizers, especially Dr. Hemapriya and team, for having given me this opportunity for me to speak to you regarding this very not very commonly encountered but very serious illness called ischemic heart disease among pregnant women. So we all know that. Yeah, we all know that heart diseases in pregnancy are basically they were marred by the conventional congenital heart disease, rheumatic heart disease, and cardiomyopathy so far, and they are hardly for around 1% of the total heart disease in pregnancy. So incidence is hardly 1%. But of late, from last 2 to 3 decades or so, because of various reasons, we have started encountering good number of ischemic heart disease patients. So practicing in India in 2024, anecdotally speaking, even myself, I have for more than 10 years of cardiology experience. I've hardly treated maybe around 4 to 5 patients with ischemic heart disease per se among pregnant women. But nevertheless, it is increasing globally, and the trend is also same in India. Now, the current incidence of IHD among pregnant women is anywhere between 0.6 to 10 per lakh population. Now, this is an interesting slide. Here, the presumed etiology of ischemic heart disease can be seen in first trimester, second trimester, third trimester, during labor and postpartum period. So these are various etiologies: atherosclerosis, thromboembolism, coronary dissection, coronary spasm, and other are unexplained etiology. What you start noticing here is that the more number of ischemic heart disease events start happening during the third trimester, or probably during delivery or peripartum period, or even during the postpartum period. So, although the atherosclerosis significantly contributes, one thing you should remember is that there is an entity called coronary artery dissection, that is spontaneous coronary artery dissection, otherwise called as SCAD, which is also contributing to nearly 2/3 patients of pregnant women who are having ischemic heart disease. So now, what are the predisposing factors? Why have we started getting more and more number of pregnant women becoming ischemic heart disease patients? Because you don't see these patients, don't expect them to be having ischemic heart disease, given that ischemic heart disease is a degenerative, aging process. So one of the most important causes globally, at least if not in India, is smoking. Of course, India is no different now. The current generation have started smoking, whether it is vape, from tobacco, whatever it is, increasing maternal age for various reasons, social, economical, financial, so many reasons are there. Increasing maternal age, familial dyslipidemia, preeclampsia, which is extremely important, although it has started coming down in India, still it's a major problem, preeclampsia, eclampsia, and worsening or pre-existing hypertension, and diabetes mellitus, thrombophilia, multiple transfusion during delivery or, pregnancy for whatever the reason, during LSES, postpartum infection and other, aortic dissection, prostaglandin use, etc., are also contributing or risk factors for heart diseases. So ischemic heart disease. So what are the physiological changes in pregnancy contributing to or unmasking the ischemic heart disease? We all know that. I don't want to go into the details, that there are a lot of physiological changes that do happen among pregnant women. The most important being increase in intravascular volume by more than 50%, reaching the summit or zenith by mid-trimester, and increased plasma volume with an associated increase in stroke volume, and increased cardiac output approximately by 25% during the first trimester, 50% during the second trimester, and up to nearly 80% during the third trimester. And at delivery, there may be a further, auto transfusion, as well as, postpartum bleeding or peripartum bleeding, which also, can give rise to the precipitation of underlying coronary artery disease. So coming to the epidemiology of ischemic heart disease among pregnant women. So pregnancy may increase the risk of MI by 3 to 4 times. Although this is a fact, this is not often seen in the routine clinical practice unless there are other compounding, risk factors which are, heralded by or, inherited by the patient, whether it is smoking or dyslipidemia or family history, etc., etc. So the incidence is anywhere between 3 to 10, as I said earlier. MI in pregnancy is associated with disproportionately high mortality, maternal mortality. This is, from various registries, it varies anywhere between 5 to 37%. That is too much. Almost, 41 in 3 women we are going to lose. Among these cases, only 13% of the patients were known to have CAD, which was there prior to pregnancy. And 2/3 of the women suffered from MI in the 3rd trimester. That is very, very important. This is what I wanted to drive home, even during the earlier slide also. So majority of the MIs do occur during the 3rd trimester and also peripartum period. So continuing with epidemiology, mortality of those women, for those women in 3rd trimester was nearly 45% as compared to 23% in patients who had an infarct in the 1st or 2nd trimester. So if that means if the patient were to have an MI during the 3rd trimester, the prognosis is far worse when compared to those who had, MI during the 1st or 2nd trimester. The fetal loss rate is primarily related to the maternal outcome. However, overall fetal loss can be attributed to as much as around 40%. So now coming to the symptoms of ischemic heart disease in pregnancy. Are they really different from, the common ischemic heart disease symptoms in the general population? The answer is truly no. But however, we should remember certain things. What are those? One is there are usual symptoms associated with physiological changes in pregnancy. What are those? For example, the breathlessness and exertion, intermittent palpitations, mild fluid retention, mildly elevated JVP, third heart sound, which can be physiological, soft systolic murmur, which is grade 1-2 murmur, and resting tachycardia. So these are all some of the things which are commonly encountered by our obstetricians or treating doctors among all pregnant women. However, if these things, if they become extreme, for example, extreme breathlessness, chest pain, orthopnea, paroxysmal nocturnal dyspnea, nocturnal cough, tachycardia, persistent tachycardia of more than 100, although tachycardia itself is a feature of pregnancy, and fourth heart sound, or systolic murmur of more than grade 3-4, and pulmonary edema and pleural effusion, all these things can be an harbinger of underlying ischemic heart disease. So what are the general symptoms as such? They can be chest pain, there can be diaphoresis, dyspnea, palpitation, decreased exercise tolerance. All those things can be there, which are akin to those seen among common man, so general population. So now coming to the symptom severity and prognosis of heart disease in pregnancy. So this is applicable to all structural heart disease. Given that ischemic heart disease is also a structural heart disease, those who are having New York Heart Association functional classification 1 and 2, they will have a decent outcome, fair prognosis or good prognosis, compared to those who have a functional class of more than 3 and 4. Here, I just would like to point out certain things to you. One is, the cardiac conditions with a prohibitively high mortality or maternal mortality risk are, for example, Eisenmenger syndrome, Marfan syndrome with aortic involvement, pulmonary hypertension, coarctation of aorta, etc. When these conditions are encountered, the termination of pregnancy is mandatory and it should be done as early as possible, at least, before 12 weeks. However, are we justified in doing termination of pregnancy if somebody ends up with an MI during 1st or 2nd trimester? The answer is no. However, we have to take multiple things into consideration. What is the patient's functional reserve, what is the LV ejection fraction, etc., etc. So now coming to the management, this is always a team approach. Remember, if the team is not involved, if multiple people are not involved, cardiologists, nursing staff, anesthetists, more importantly, the obstetricians who are treating the patient from quite long time, they would be knowing before pregnancy, during pregnancy, and also peripartum period, postpartum period also. Every detail of the patients will be known to these obstetricians, and without their, collaborative effort, these patients cannot be managed very effectively. So the thumb rule is to manage these patients with multidisciplinary approach. Now, what are the diagnostic dilemmas? There are some diagnostic dilemmas that I mentioned in the earlier slides also, because high index of suspicion is very much required here, because the majority of the signs and symptoms are maybe, commonly seen among those patients or those pregnant women who are otherwise not having ischemic heart disease also. Only when these symptoms are, very significant, or when these symptoms are worsening, probably we have to, we have to, pay little more attention. However, in a given patient, every patient we have to individualize, because these symptoms have to be carefully monitored. And if you feel anything unusual, these patients have to be evaluated for ischemic heart disease also. The physiological changes that are normal in pregnancy may aggravate pre-existing disease, or they may also unmask the underlying unrecognized coronary artery disease. And now coming to the management of ischemic heart disease, it always requires multidisciplinary approach. This is mandatory. Unless we do consider this multidisciplinary approach, the outcomes may not be great. So myocardial infarction etiologies among pregnant women. So this I have already mentioned. Atherosclerotic heart disease is the most common one, followed by embolic complications and SCAD, coronary artery dissection, spontaneous coronary artery dissection, and coronary artery spasm. This is another entity. And ergot-induced, ergotamine and other substances should be avoided in these patients. And collagen vascular disease and congenital malformation and other rare causes like pheochromocytoma, sickle cell anemia, and Kawasaki disease may also contribute. So now coming to the diagnosis, symptoms and signs are no different from general population. However, we have to differentiate these from the physiological symptoms of pregnancy. The occurrence of sweating, faintness, chest pain, fatigue, these are all very, very, dangerous symptoms. They have to be evaluated properly unless there is another alternating explanation to explain them. Physiological EKG changes, the EKG changes can be, depending on whether the patient is having NSTEMI, unstable angina, STEMI. So they can be from the EKG can be completely normal to, complete ST elevation to non-specific STT changes. That all depends on the patient's presentation. So the EKG changes should not be completely dogmatically dependent on, because there may not be EKG changes, but still the patient may be having an underlying ischemic heart disease or acute coronary syndrome. So now what are the other investigations? Cardiac biomarkers are very important, although there is some evidence that the pregnancy can itself induce little elevation in troponin T and CKMB, but significant elevation in troponin I is still, very, very important cardiac biomarker to prove the diagnosis of ischemic heart disease. And CKMB may be elevated, but however it lacks specificity. Elevated LDH is not very much reliable. But there is one entity which they have been exploring of late, is pregnancy associated plasma protein. So this is one of the circulating proteins in the maternal plasma and is present in unstable plaques. What are unstable plaques? In coronary artery disease, in the coronary arteries, there can be plaques. These plaques can be stable plaques or unstable plaques. Unstable plaques are the ones which will rupture and probably give rise to an acute coronary syndrome than the stable plaques. So if you evaluate this pregnancy-associated plasma protein A, that is PAP-A, you may be able to delineate the unstable plaques in a given woman, pregnant woman. ECG features may vary from normal to frank ST elevation to non-specific STT changes, as I mentioned earlier. What are the other investigations? Coming to imaging, you have wonderful echo, bedside tool in which hardly can be done in 300 to 500 rupees cost. It is 2-dimensional echocardiography, which will tell you about regional wall motion abnormality and various other mechanical complications. It could be, papillary muscle dysfunction, MR, new onset, pericardial effusion, whatever it is. There are a lot of things that can be picked up by echocardiography. Radionuclide imaging, although people in research articles do mentioning about this one, this is not very commonly employed, even in general population also, unless we are trying to delineate the underlying, stress evaluation. So the cardiac catheterization should be considered. However, a decade back or 2 decades back, this was one thing which was actually prohibitive. Like people were discouraging from considering cardiac catheterization. Now, if the patient were to be suffering from STEMI, that means the coronary artery is completely occluded. Probably these are the category of patients. They should be promptly subjected to coronary angiogram. And if there is need, these patients should be intervened. Cardiac MRI can be rarely of use. And now coming to the management of pregnancy with ischemic heart disease. So when it comes to managing the labor in patients with impaired coronary circulation or ischemic heart disease, multidisciplinary team with cardiologist, obstetrician, anesthesiologist, all interventional, perinatologist and cardiac surgeon, all are required. And now the delivery, normal vaginal delivery is the one which is commonly indicated unless the patient is having, advanced heart failure or there is some structural problem which is inhibiting or prohibiting from subjecting the patient for normal vaginal delivery. Then in those patients, maybe you can, cut short the second phase of delivery using forceps or other, this one, or the patient can be subjected for cesarean section. Consider epidural or instrumental cutting short of the second stage of labor, or consider epidural anesthesia, especially if you require to give anesthesia in these patients. Continuous maternal cardiac monitoring extremely important. Continuous electronic fetal monitoring is also very, very important. And caution with fluid management is very much necessary. And avoid administration of ergometrin, which is in fact contraindicated in these patients who are having ischemic heart disease. If surgery or other interventions are needed, consider emergency cesarean section. And post-delivery maternal cardiac monitoring for at least 48 hours in intensive care unit is mandatory. So now, what are the other management aspects that we should keep in mind? Delivery should be delayed, especially if the patient has sustained an acute MI. So in late pregnancy, delivery should be delayed ideally for at least 2 weeks. After the onset of infant, and prolonging the interval is shown to reduce the mortality rate from nearly 50% to 35% or even less. The ideal delivery position in these patients is the lateral recumbent position, which will avoid vena cava decompression and associated cardiac complications. And prolonged ICU care for frequent assessment of signs and symptoms of heart failure and ventricular arrhythmias is very much necessary. And intravenous lidocaine is the drug of choice for managing, various MI-associated arrhythmias. The use of, Lasix and furosemide. And pregnancy may be, is an hypercoagulable state, so you can use heparin, which is not contraindicated. And nitroglycerin and other, the routine medications which are being used in ischemic heart disease may not be, you cannot say they are contraindicated. They are not generally recommended. However, for example, statin is generally not recommended. However, in a patient who has sustained an MI, so these medications can be used with caution, including your, thienopyridine derivatives, that is the dual antiplatelet therapy. Aspirin is not contraindicated. Statin, you may have to avoid during pregnancy because of teratogenicity and other things. And, other medications like nicorandil, trimetazidine, or for example, nitroglycerin, all those things can be used with caution, although it is not generally recommended during pregnancy. So what are the other management aspects that should be kept in mind? One is thrombolytic therapy. Whether we can consider thrombolytic therapy, it is risky. So in 2024, if you want me to talk about management of ischemic heart disease patients or acute coronary syndrome, it is better to take them for primary PCI rather than thrombolytic therapy, because which will increase the maternal bleeding as well as the placental bleeding. So although if someone has to use thrombolytic therapy where primary PCI is not possible for STEMI, then you can use probably the latest molecules such as tenecteplase and other things, tissue plasminogen activators as a thrombolytic agent. CABG carries a little higher mortality. So the fetal loss rate is approximately around 33% when compared to, the mortality is little higher when compared to general population. So what are the modes of delivery? So timing of delivery is very, very important. The maternal mortality is inversely related to the interval between the infarction and the delivery. So longer the delivery, better the prognosis. Longer the duration or the interval, the better the prognosis. Within approximately 5 to 7 days after MI, acute myocardial infarction, a degree of stability will return to the mother, both in terms of, the structural complications as well as maternal ventricular function, and the risk is little lower. However, if you increase the duration to more than 2 weeks, then probably it is better. Analgesia in labor, it is always better to consider epidural anesthesia as the method of choice in these patients. So vaginal delivery should be the method of choice. However, only in certain patients who are having acute decompensated heart failure, another mechanical complication, patient is having pulmonary edema. So maybe those are the patients in whom you should consider, the augmented, instrument augmented cut shorting of second stage of labor, or for example, cesarean section. The reported maternal mortality with vaginal birth rate after MI is around 14%, whereas mortality in patients delivered by cesarean section is nearly double, almost 23%. So LSCS indicated only for maternal indications and in those patients who are having acute decompensated heart failure. Oxytocin is the drug of choice for controlling the postpartum hemorrhage, and ergotamine and compound should be contraindicated. So what are the preconception counseling that one should do. So it is suggested that the subsequent pregnancy in a patient who has sustained an MI, so definitely will increase the risk during the subsequent pregnancies, and if possible, they should be avoided just the way they avoid in peripartum cardiomyopathy. The period between MI and the pregnancy should be more than 1 year, if at all the lady is considering to, become pregnant one more time. The patient should have had a recent negative coronary angiogram, or the patient should not have any significant reduced LV function before she conceives next time. So now coming to the summary of my talk. So ischemic heart disease, although very rare, but it's a very, very serious complication, especially during pregnancy. It involves many modifiable risk factors, and these risk factors we have to attend as treating clinicians. We have to, discourage the patient from, smoking. We have to make sure the patient is not having, if the patient is having familial hypercholesterolemia, etc., their cholesterol is modified, prior to becoming pregnant. And if she is having any eclampsia or hypertension, etc., they should be treated well. Poses challenges in both diagnosis as well as management, and multidisciplinary approach is the team approach is the key, and it carries disproportionately high maternal mortality and fetal loss unless these patients are managed really well. And management does not differ too much from regular ischemic heart disease cases, and timing to delivery and next pregnancy is extremely important to avoid further complications. I think if there are any questions, I will be answering at the end. Thank you very much for your patient listening. Thank you.
Thank you, Dr. Manjappa, for that brilliant talk. It's a very important diagnostic and as well as therapeutic dilemmas. There are plenty of dilemmas because the clinical situations are so variable, from ischemic heart disease, premature atherosclerosis, to embolic phenomenon, to spontaneous coronary artery dissections. A wide variety of diseases can cause acute myocardial infarctions. Right from the time of diagnosis, because we never think of a myocardial ischemia or infarction in a pregnant lady because we mentally exclude these young women from our spectrum of ischemic heart disease patients. So these are the various challenges that we see in day-to-day life, and a combined approach, like you rightly pointed out, is extremely important. And communication between the various components of the team. Sometimes there is a combined team which is treating that, but the team is not effectively communicating with each other, in which situation we see that several treatment gaps do occur in these patients. So we'll discuss and raise some important points. I hope there would be some questions about the diagnostic challenges and the therapeutic challenges in pregnant women with ischemic heart disease. But now we'll move on to the next speaker, Dr. Yatish, who is again my very good friend, and he's chief of cardiology at Adi Chanchandgiri Super Speciality Hospital. He did his MBBS from MMC and MD from King George Medical College, Lucknow, and DM Cardiology from Kanpur. They're very eminent cardiologists doing several complex procedures independently at AIIMS, and he has been responsible for setting up of the department there. And I think that would be a good introduction of Dr. Yatish. And he'll be speaking of another important crisis in pregnancy. If the patient has arrhythmias, what do you do for a pregnant lady with arrhythmias? In a general situation, we have several answers in form of drugs or ablation or various modalities of treatment. But in a pregnant lady, these options become limited and treatment becomes quite challenging. And whether to treat these arrhythmias or not, or whether to manage very conservatively, becomes an important clinical question, especially when the arrhythmias are malignant. I now request Dr. Yatish to start his talk on arrhythmias in pregnancy. Dr. Yatish.
Thank you, sir. Thank you for the nice introduction, sir. And actually, it's an honor to speak with the eminent obstetricians and cardiologists in and around the Mysuru. And directly starting the topic, arrhythmias in pregnancy. Is my slide visible, sir?
No, Dr. Yatish, I think you will
have to share your screen. Yeah, it has started. Yeah. Make it slideshow and proceed.
Yes, arrhythmias in pregnancy. Actually, arrhythmias in pregnancy is the vast topic. It has to be covered and the multiple topics, SPTs, VTs, and all. I will try to taper it to the today's sessions involving pregnancy. So most of the patients, pregnant patients, have a sinus tachycardia. Apart from it, the most common rhythm abnormalities in pregnancies are premature ventricular and atrial ectopics. It is seen in as much as 50 to 60% of pregnant patients presenting with palpitations, and which generally resolve spontaneously after delivery. And arrhythmias in pregnancy are more prevalent in structural heart disease, and one has to consider for further evaluation for those patients suffering from structural heart disease. In addition to the advanced maternal age and socioeconomic status, underlying cardiovascular disease and congenital heart disease and cardiovascular morbidities, hypertension, diabetes, obesity contribute to the increased arrhythmia risk. Arrhythmias are the most common pregnancy complications in women with cardiovascular disease and present earlier in pregnancy, stressing the need for vigilance in this group. Pregnancy itself is a pro-arrhythmic state because there is increased plasma catecholamine concentrations, chronotropic effects of relaxin, mechanical effects of atrial stretch, increased ventricular end diastolic volume caused by intravascular volume expansion, and hormonal and emotional changes all contribute to the development of pro-arrhythmia state. As such, heart rate progressively increases during pregnancy, resulting in 10 to 25% increase from pre-pregnancy values. Cardiac output rises in first and second trimester, increasing by 45%. Estrogen and relaxin stimulate nitric oxide production, which increases peripheral arterial compliance and decreases vascular resistance. Normally, pregnancy is associated with increased sympathetic activity and decreased parasympathetic activity, which in turn contribute to the development of atomicity, re-entry, and triggered activity, which all causes arrhythmias. Most of the patients reaching the cardiologist, most of the frequent symptom is palpitations. Palpitations in pregnancy, one has to properly evaluate it. And if it is found to be indolent, the patient should be reassured. Palpitation is the frequent symptom in pregnancy, and that in the majority of the patient, it is caused by either no or minor arrhythmias. Patient with extrasystoles or sinus tachycardia on ECG documentation during ongoing symptoms generally do not require further evaluation. In a study, it has shown that sinus tachycardia is found in 9%, sinus bradycardia in 1%, atrial extrasystoles in 56%, and ventricular systoles in 49% of patients presenting with palpitations in pregnancy. Other than the arrhythmias, other causes of palpitations like anemia due to bleeding, thyroid dysfunction, infection, electrolyte abnormalities, and other underlying medical conditions should be considered. ECG documentation during ongoing palpitation will allow the clear-cut diagnosis and to evaluate the type of arrhythmias. Some of the recommendation to consolidate this slide, if it is if the ECG is taken is during a palpitation and there is occurrence of PVCs or premature atrial complexes, one should be only it needs reassurance. Patients with suspected arrhythmic etiology of unexplained palpitations who are concerning symptoms or suspected electrical or structural heart disease, one should undergo ambulatory, that is Holter monitoring, and evaluation with the cardiologist and electrophysiologist. Sole consideration of electrophysical study for the evaluation of indolent arrhythmias is completely discouraged. Another most important is pre-syncope and syncope in pregnancy, which can be as indolent as just a vasovagal syncope, or sometimes it can be a very malignant one. Vasovagal, the most frequent etiology is reflex-mediated vasovagal syncope. The proper history taking at the initial evaluation will itself will diagnose that it is a case of vasovagal syncope. Longer duration of standing, in very rare cases, sitting up from supine position, hypovolemia due to bleeding or vomiting, such as hyperemesis gravidarum, and warm environment may exaggerate the symptoms. As in non-pregnant patient, initial evaluation with detailed history is diagnostic for typical reflex-mediated vasovagal syncope during pregnancy, which is associated with favorable prognosis. So how to approach? If it is a vasovagal syncope, just a 12 ECG, 12-leaded ECG, and if needed, an echocardiogram is more than enough. Or if it is associated with some structural heart disease or some grievous other cardiac condition, one should be properly evaluated. Holter monitoring is necessary. If it is necessary, there is a need for imaging such as cardiac MRI, and involvement of cardiologist and electrophysiologist is recommended. In case of 3 days Holter monitoring is not diagnostics, one can consider intracardiac monitoring is also recommended. In pregnant patient with unexplained syncope, but without evidence of cardiac disease or conduction system disease, diagnostic electrophysiology study, again, it is not recommended. Apart from the premature atrial complexes and premature ventricular complexes and sinus tachycardia, other supraventricular tachycardias like AVNRT and AVRT, atrioventricular nodal re-entry tachycardia, and atrioventricular re-entry tachycardia are the most common cardiac arrhythmias to present during pregnancy. Most commonly present with palpitations, sometimes can present with pre-syncope, syncope, dyspnea, or chest pain. Especially, SVT especially occurs during second and third trimester. Incidence of atrial fibrillation and atrial flutter, though it is increasing nowadays, it is low in pregnant patients without structural heart disease. For both AVNRT and AVRT, AV node is required component of the re-entrant circuit. Maneuvers which slows the AV conduction can terminate SVTs. Vagal maneuvers such as Valsalva maneuver or carotid sinus massage are simple methods for terminating SVT and are safe to attempt in a pregnant patient before resorting to any pharmacological therapy. This is a guideline-directed management of SVT. First, one has to summarize this recommendation. We can directly go for a flow chart. Those patients coming with SVT, if it is an acute onset, one should try the vagal maneuvers like the carotid sinus massage or Valsalva maneuver. If hemodynamically unstable, directly go for the cardioversion, synchronized direct cardioversion. If the patient is hemodynamically stable, blood pressure is stable, respiration is normal, saturation is normal, one can attempt intravenous adenosine as a first-line pharmacological therapy. If it is ineffective, they can go for, again, intravenous beta blockers involving metoprolol or propranolol. If it is still ineffective in controlling SVT, one can attempt calcium channel blockers, verapamil or diltiazem, or intravenous procainamide. This in case of hemodynamically stable VT. For those patients with recurrent or persistent SVT, one can give a prophylactic metoprolol or propranolol or digoxin. Even digoxin is found to be safe in pregnancy. Verapamil, though some studies shows that it causes miscarriage when all other measures fail, verapamil is also recommended as a second-line pharmacological therapy. For symptomatic focal atrial tachycardia, the beta blocker is the first line of option. This management only if there is no pre-excitation, that is, there is no WPW syndrome. If SVT is associated with the WPW syndrome, one should consider treatment with oral flecainide or propafenone. Other alternative antiarrhythmic drugs like flecainide, propafenone, and sotalol are recommended as a second-line agent. If it is refractory, then one can consider catheter ablation or amiodarone, considering the risks and benefits of both. Catheter ablation, nowadays, it has been done without with minimal use of fluoroscopy or without fluoroscopy. So where the catheter ablation is most effective, one should consider going for catheter ablation. We'll discuss in detail on later slides. Valsalva maneuver requires that the patient bear down against the closed glottis for 10 to 30 seconds and is performed with the patient in a supine position. Other than Valsalva maneuver, carotid sinus massage is performed by applying pressure over the right or left carotid sinus for 5 to 10 seconds. Auscultate the carotid and ensure that there is no brevi or carotid artery stenosis before giving the carotid massage. Ice cold wet towels on face or facial immersion in cold water or alternative vagal maneuvers. The practice of applying pressure to the eyeball is no more recommended when we have other measures. Acute onset SPT, if it is associated with hemodynamic instability like syncope, pulmonary edema, cardiogenic shock, hypotension, and brain perfusion, one has to consider giving direct cardioversion is recommended. It should be treated promptly. Electrode should not be applied to the breast tissue. The energy dose administered is similar to that in the non-pregnant patient. Fetal monitoring is appropriate after cardioversion if warranted by concerns about fetal well-being. This is the placement of defibrillator pads. One can apply in the sternal and apical region. Please avoid the breast tissue because breast tissue may get damaged and it will give inadequate doses of current. Or one can give front and back, anterior and posterior, and the pads can be placed there. Atenolol, age-old beta blocker, is best avoided because all the studies have showed that it is associated with lower birth weight when compared to other agents. Sole premature atrial complexes do not require any treatment. Avoid caffeine, alcohol, stimulants, and other beta agonists. Digoxin, metoprolol, propranolol, and verapamil are not found to be teratogenic. We have a vast data involving all these drugs. These are not found to be teratogenic. When necessary, lowest possible dose of beta blockers should be used because sometimes they are associated with low birth weight, bradycardia, and neonatal hypoglycemia. Digoxin, metoprolol, and propranolol have a robust safety profile during pregnancy and favored as an initial option. Management of atrial fibrillation and atrial flutter in pregnancy. To summarize this recommendation, I will just summarize this chart. Atrial flutter accompanying hemodynamic compromise or pre-exertion, direct cardioversion should be given. For those patients present with AF, first try with the intravenous beta blockers. Not controlling, give digoxin. Not controlling, give calcium channel blockers as a second line agents. Anticoagulation is recommended as in case of non-pregnant patients. If all these beta blockers and calcium channel blockers are contraindicated, one can try with ebutalide or flecainide in the absence of structural heart disease, and sotalol in the absence of severe LV dysfunction. If atrial flutter is amenable to the ablation, one should consider catheter ablation as a first line of treatment. Ebutalide can safely administered for the acute cardioversion from AF or AT during pregnancy without reported adverse fetal outcomes. Intravenous magnesium is often administered prior to the ebutalide to mitigate the risk of Torsades pointis. Oral flecainide bolus has been shown to be effective for acute management of atrial fibrillation. Digoxin appears to be well tolerated and safe for fetus, but less effective for maternal heart rate in the setting of high adrenergic state. With respect to the calcium channel blockers, verapamil is associated with fetal demise, hence it is to be given as a last option. Again, the flecainide or sotalol has been studied especially for giving fetal SVT treatment. It has been extensively studied and found to be safe. In the absence of concomitant fetal hydrops, sotalol appears to be well tolerated when initiated between the second and third trimester. Again, for atrial flutter, catheter ablation should be considered. Another most important is anticoagulation in pregnancy, whether for atrial fibrillation or any other recommendation for anticoagulation. This is one of the most important consideration where one should involve cardio-obstetric team. The meta-analysis data in a pregnant population with the mechanical heart valves show that low-dose warfarin, less than 5 milligram, used throughout pregnancy has significantly lower risk for fetal embryopathy than higher dose warfarin. So this is one of the most important table. For those patients who want to achieve the required INR, if the warfarin needed is less than 5 milligram, one can continue with the warfarin. Sometimes one can start with the low molecular heparin in first trimester, second and third trimester, continue with the warfarin. From 36 weeks to 36 hours of delivery, low molecular weight heparin is given. From 36 hours after delivery to the pre-delivery, one can give unfractionated heparin, which has a half-life of 4 hours. It should be stopped 6 hours before delivery. For those patients requiring more than 5 milligram of warfarin, one can consider giving low molecular weight heparin throughout pregnancy and overlapping with unfractionated heparin till 6 hours before delivery. And as of now, the direct oral anticoagulants like the apixaban, rivaroxaban, and dabigatran, we don't have much of study, especially in pregnant patients. Rivaroxaban use has found to be associated with miscarriage and 4% anomalies. Hence, all direct oral anticoagulants should be avoided during pregnancy. Management of ventricular arrhythmias in pregnancy. To summarize, ventricular tachycardia and this chart, any patient presents with ventricular tachycardia, if it is acute VT, hemodynamically compromised, directly go for a direct cardioversion. If hemodynamically stable, one can give intravenous procainamide. If VT is sustained or refractory to the antiarrhythmic medication, start giving synchronized cardioversion. If idiopathic ventricular tachycardia or RVOT VT is there, one can give injection adenosine, or if it is a fascicular VT, one can give injection verapamil. Ongoing management of recurrent or chronic VT, one can consider pharmacological therapy with a beta blocker or in combination with other antiarrhythmic drugs like flecainide or sotalol or mexiletine. Or if it is very much amenable to the catheter ablation, one can go for catheter ablation. Or if all these are contraindicated or ineffective, one can consider amiodarone. For those patients who are risk of sudden cardiac death, one should consider ICD. If the substrate for and requirement for ICD before pregnancy itself, before conception itself is present, then one should undergo implantable cardiac defibrillator implantation prior to planning pregnancy. During pregnancy, if there is indication, it can be taken in the second and third trimester. Or if it is near to delivery, one should go for a delivery. In case of reversal peripartum cardiomyopathy, one can consider wearable defibrillator if the risk of VT is there. Another most important is considerations amiodarone pregnancy. In non-pregnant patients and adult patients, for any VT or atrial fibrillation, we left and right use amiodarone. But during pregnancy, it is to be used as a last option where all others measure fails. The most common complication of use of amiodarone in pregnancy is fetal hypothyroidism, which is typically transient and effectively treated with short-term therapy. Monitor for fetal hypothyroidism. Amiodarone has a potential for direct neurotoxicity, which may lead to neurodevelopmental abnormalities. Nevertheless, the potential risk has to be balanced against the detrimental effects of intractable ventricular arrhythmias, which is very detrimental to both mother and fetus. The dose and duration of amiodarone should be minimized as less as possible. Another important is peripartum cardiomyopathy. More than 70% recover, so hence ICT is not indicated. But those patients with severe LV dysfunction, with elevated end-diastolic volume 6 or more than 6 centimeter, usually won't recover by 1 year. Hence, consideration if they are associated with arrhythmias, one should consider ICD implantation. Those patients, the pregnant patient, if presents with bradycardia heart block, one should consider temporary ventricular pacing as an emergency management. Advanced heart block or conduction system disease, one should further evaluate with the echocardiogram or cardiac MRI. Those patients with third-degree heart block, second-degree Mobitz type 2 heart block, severe sinus node dysfunction, those present with syncope and pre-syncope should promptly be treated with permanent pacemaker implantation as early as possible. Congenital complete heart block, those with almost normal ventricular rhythm, one should defer placement of permanent pacemaker until after delivery. Prophylactic temporary pacemaker is not recommended for asymptomatic congenital heart block patient with acceptable ventricular rate, narrow QRS complex, and normal ventricular function. This is what it is summarized. Only thing is, for sinus node bradycardia and type 1 and Mobitz type 1 AV block, only reassurance is needed. Hemodynamically stable asymptomatic congenital heart block, defer pacemaker implantation until after delivery. If there is a symptomatic severe bradycardia, one should consider permanent pacemaker implantation, bridging with temporary ventricular pacing. Use of gadolinium contrast is to be avoided during pregnancy. Permanent pacemaker implantation with modern technology, one can implant pacemaker with minimal fluoroscopy or no fluoroscopy. All hemodynamically significant bradycardia should be treated with TPA, temporary pacemaker. Another most important topic is cardiac arrest in pregnancy. How it differs from the resuscitation in cardiac arrest in normal adults. There are few differences. In addition to the standard causes of cardiac arrest, amniotic fluid embolism, pulmonary embolism, peripartum cardiomyopathy, and acute coronary aortic dissection, one should consider. In later stages of pregnancy, the uterus can reduce the venous return because of aortocaval compression, particularly in supine position, and sometimes it has been studied that it has been case reports that they will present with cardiac arrest, and prompt resuscitation with emergency cesarean section has found to be successful in resuscitation of both mother and fetus. Peri-arrest cesarean section is performed to aid the resuscitation of mother rather than to save the baby. At approximately 20 weeks, the uterine fundus is palpable at the level of the umbilicus and may start to adversely affect the hemodynamics in supine position. So any patient who are undergoing this one cardio-resuscitative efforts, the uterine should be tilted with manual tilting. Manual leftward and upward uterine should be displaced so that it will avoid the aortocaval compression and help the resuscitative efforts. Transportation of the patient from the site of cardiac arrest for resuscitative hysterotomy is associated with significant delay in completion of the procedure and with worsening maternal and neonatal outcomes. So the guidelines recommend that do a resuscitative hysterotomy as a way the patient has gone cardiac arrest and or resuscitative measure is going on. Unnecessary shifting the patient to the OT is to be avoided. And the delivery hysterotomy should be performed within less than 5 minutes of cardiac arrest. uterine evacuation should be done within 5 minutes of cardiac arrest. If the cervix is already dilated and the patient develops cardiac arrest, one should consider assisted vaginal delivery. It can act as alternative to resuscitative hysterectomy to evacuate the uterus. This is again the chart that summarizes the entire guideline recommendations. More than 20 weeks as usual for the ACLS and BCLS. One should give, if it is a shockable rhythm, give shocks. If it is non-shockable rhythm, consider other diagnosis with the consideration of leftward and upward uterine displacement. Chest compression with hands placed at the center of the lower half of the sternum as usual in other patients. Those patients who are diagnosed with arrhythmia structural heart disease, one should consider preconceived genetic counseling should be considered and should be properly evaluated for further deterioration by using ECGs and echocardiography during pregnancies. And one should undergo ICD or should be treated with sotalol or flecainide to avoid any arrhythmias during pregnancy. Those patients with Brugada syndrome, long QT syndrome, or catecholaminergic polymorphic ventricular tachycardia, it should be strategized, and level 3 surveillance is needed. Those who presents with the recurrent episodes of events. Level 3 surveillance means involvement of arterial line, external cardiovascular defibrillator, preparation for intravenous beta blockers, antiarrhythmic drugs, and some other as involvement of cardio-obstetric team. Another last topic, the fetal tachyarrhythmias. If the fetal arrhythmias, if it is less than 50% of the time or less than 12 hours duration per day, if it is not associated with fetal eye drops, only reassurance is needed. If it is intermittent arrhythmias without eye drops, observation, frequent heart rate monitoring, and serial biophysical testing is needed. If it is incessant arrhythmias for more than 50% of times or more than 12 hours, one should consider, if it is a term, one should consider delivery immediately, or preterm, one should consider placental flecainide or sotalol, or in combination with digoxin, or transplantal administration of amiodarone or digoxin should be considered. Transplantal therapy with the verapamil is potentially harmful. By this, I will end my topic. The most important take-home messages are PACs and PVCs is the most common arrhythmias in pregnancy. Hemodynamically, SVT and hemodynamically unstable SVT and VT should be aggressively treated to achieve the hemodynamic stability. Care of arrhythmias in pregnant patients should involve a multidisciplinary approach involving cardiologists, electrophysiologists, pediatric electrophysiologists, maternal and fetal medicine subspecialists, obstetricians, anesthesiologists, and neonatologists to optimize the outcome for both mother and fetus. Procedures such as catheter ablation and implantable devices, if indicated, one should consider. The most safe drugs are propranolol, metoprolol, nadolol during pregnancy. Even quinidine, sotalol, and digoxin is found to be safe. Please avoid atenolol at any cost. Thank you. Thank you for bearing with me. It's a vast topic.
Thank you, Dr. Yatish, for that elegant talk on arrhythmias, and I'm sure you have resolved several doubts in our minds about the treatment of arrhythmias in pregnancy. I now request my co-chairperson, Dr. Pushpalata, to proceed with the introduction of the next speaker and continue this session.
Thanks a lot. I request Dr. Hema to just post the introduction of the next speaker, Dr. Shweta Naik, please.
Yes, ma'am. Yes, I shall just share the screen.
Good morning, everyone. After 3 sessions of cardiology speaking on the core topics that are hampering the obstetric outcome when there is cardiac disease, we now have the fourth speaker for the day. She's Dr. Shweta Naik. She's consultant obstetrician and gynecologist at Motherhood Hospital in Mysuru. And she has done her MBBS from WIMS Ballari, and she has done DNB from HM Hospital Mysuru, and she has worked in various institutions at various capacities. And she has done her fellowship in USG and ERT clinic, which is adding a cap to her feather as for obstetrician with subspecialty training. So it's my privilege to introduce her and welcome to present our topic on newer iron molecules. Welcome, Dr. Shweta, and over to you.
Dr. Shweta, you can share your screen.
Yes, thank you. Thank you, Madam Pushpalata. Very good afternoon to everyone. After listening to an informative and educative sessions by Dr. Sunil Kumar, Dr. Manjappa, and Dr. Yatish, it's my turn. And my presentation is a customary presentation from the MQ Pharma about their new iron molecule. Without wasting much time, let me just take you to the presentation itself. Yeah. So the commonest link between cardiologist and gynecologist is anemia, where the presence of which hampers the prognosis in both the cases. Whether it is gynecologist, when we encounter any anemia in our patients, we do have fear of having fetal growth retardation and all labor associated problems, and most dreaded one being postpartum hemorrhage. And as far as you know, anemia is not expected for any cardiological cases as well. But other than this, anemia has got a common thread in Indian people also. Though India is known as a country of unity in diversity, other than the castes, politics, and regional variations, anemia is one single thread which commonly binds all the Indians. As we all know, anemia affects nearly 2 billion people globally, and it has got a very high impact on women for a greater degree than men. So this is one slide, customary slide showing the WHO classification of severity of anemia in reproductive age group. Here, the classification has been done between non-pregnant women and pregnant women. In non-pregnant women, mild anemia is considered as a range between 11 to 11.9, whereas in pregnant women, it is considered as 10 to 10.9. And moderate anemia in non-pregnant women is 8 to 10.9, and in pregnant ladies, it is 7 to 9.9. And it is considered as severe anemia in non-pregnant women when it is less than 8, and it is considered as severe in pregnant ladies when it is less than 7. So all these slides are based on National Family Health Survey India, session 5, where this survey provides most information on anemia, fertility, practice of family planning services, infant and maternal mortality rates, and nutrition. Hence, the data data which I am presenting will be taken from this survey. As you can see, we all know that a significant non-pregnant population also have anemia, and it is believed that 1 out of every 2 patients has got the risk of anemia. Here, what we can see is that even in non-pregnant, 57.2% people have anemia, whereas in pregnant ladies, it is around 52.20, where we can explain their anemia. But how to explain the occurrence of anemia in non-pregnant ladies? So it is really difficult to explain. So what is the reason? According to NFHS survey, the prevalence of anemia, severe anemia, has reduced to 2.69, which is a very good news. But what is bothering us is that About 28.49% of the population are still suffering from moderate anemia. So, though the occurrence of severe anemia has reduced, which can contribute to our reduced maternal mortality rate, the occurrence of moderate anemia can affect our lifestyle. Similarly, in pregnant ladies also, moderate anemia, incidence of moderate anemia is increasing year by year. So what is the normal recommended iron RDA for iron? For adult men, it is about 19 milligram per deciliter, and for adult women, it is around 29 milligram per deciliter. So here what we have to remember is that this is the smallest amount of iron which we have to provide for our women. And in pregnant ladies, almost it is doubled, that is 40 milligram per deciliter. And there could be further increased iron requirement and folic acid necessary for healthy development of the fetus. So, according to the WHO recommendation, about 40% of the non-pregnant ladies who belong to reproductive age group require about 30 to 60 milligram of iron and 400 microgram of folic acid daily for 3 consecutive months to treat the moderate anemia. And about 20 to 40% of women require 120 milligram of iron, that is therapeutic dosage of iron. Similar thing holds good for even pregnant ladies as well. In less than 20% of the population, only 120 milligram of iron is required. And about 20 to 40% of the women, about 30 to 60 milligram of iron is required. And more than 40% of the women require around 60 milligram of iron. So CDC recommends that all pregnant women should begin 30 milligram per day of iron at the first prenatal visit, irrespective of their anemic status. This is a slide showing a large chunk about the absorption of iron. When dietary iron is taken, it is absorbed in the duodenal villi and is taken in ferrous form, and with the help of ferroportin and other protein molecules is brought to the blood levels. So in this slide, what we can observe here is that there are various iron molecules available in the market, but how much of elemental iron is available for the lady does differs. Here, as we can see, ferrous fumarate has got about 106 per 325 milligram of iron tablet. But the problem with it is that it causes about 47% of side effects. So this limits the usage. Other than the therapeutic usage, for day-to-day use, we cannot use this. So next what we can see is ferrous gluconate. It has got about 35 milligram of iron content, which is available for each capsule, but the side effect rate is again high. Here, similarly, ferrous sulfate, relatively, though this is known as poor man's iron, has got about 65 milligram per capsule is available, but the side effect is again 32%. Iron protein succinyl has got very good side effect profile, but the absorption is also very poor. So here comes the need for treating a moderate anemia patients on day-to-day basis. So the current challenges associated with current oral iron therapies is that it should have less elemental iron, slower to restore iron levels, and it should be well tolerated and good compliance. These are, and along with the iron and absorption mechanism, vitamin D and vitamin B12, riboflavin, vitamin E and vitamin C have also got very good role. This is a study. So the increasing importance to consider managing anemia is beyond iron, and it includes the role of vitamin B12, vitamin D, vitamin C as well. So the oral iron therapy should have good absorption, low risk of GI adverse events, high elemental iron content. It should reduce the damage to gut microbiome. It should reduce exacerbation of any underlying tissues, gastrointestinal tissues, and it should not hamper gastrointestinal disease if any present. And it should also provide us with recommended this thing of vitamin B12, folic acid, and DNA synthesis, vitamin C, and vitamin D as well. So ferric maltol is the molecule. It has a potential to be used as a first-line treatment in mild to moderate anemia. A low dose of iron formulation containing 29 milligram is available, and it is approved in US and Europe. This is a slide showing how ferric maltol can differ from ferrous sulfate, where ferric maltol, anytime it has got no dissociation, it gets converted into maltol glucuronide and excreted in urine directly, and also it does not produce reactive oxygen species, which will cause most of the side effects. That is the advantage of ferric maltol. This ferric maltol is stable in the acidic environment of the stomach. It forms soluble iron complex. It gets dissociated upon uptake from duodenum and does not form free hydroxyl radicals. And hence, it does not cause any damage to tissues. And it gets separated from the metabolism by forming maltol glucuronide and gets excreted in the urine. That it has got less GI side effects and metallic taste. There are some studies conducted, though, which is on very small numbers, which are showing the efficacy of ferric maltol. It requires higher numbers to present it on other journals. Not here, the size sample is only 29, and it has found to be very effective in 3 months therapy. On a general note, it has caused increase in the hemoglobin to about 2.74 grams when compared to other molecules, which usually cause around 1 to 1.5 grams. So to summarize, anemia is a global concern. Of course, nowadays, mild to moderate anemia is similarly affecting the woman, and nutritional deficiencies have a big concern. Iron absorption is still a challenge, and conventional salts affect the absorption, and they have got less tolerability as well. With new forms of iron like ferric maltol, which is going to make a lot of difference in iron therapy. And iron uptake with ferric maltol is saturable, and it prevents the chance of iron low. Ferric maltol has low potential for mucosal toxicity, and it is easily tolerated by all the patients. There is a need to offer patients with the advantage of this preparation. Thank you.
Thanks, Dr. Shweta, for the very descriptive presentation on anemia and pregnancy. So the topic which propped up amidst the cardiac specific topics, but for obstetricians, this is a topic which is a main topic and which is being taught and which is practiced in our day-to-day practice. And anemia as such is an indicator of poor nutrition and poor health of the community. Definitely, we commend your efforts in bringing up the most valid, most relevant topic of the time, because we really are working to ensure that the health, well-being of the woman and the newborn he is ensured by adequate iron supplementation. That is that we want to that result, because anemia, we all know that it doesn't just impair the well-being of the mother, it results in impaired cognitive and motor development in children, thus bringing down the overall work capacity of the community. So I thank Dr. Shweta, and we really have to come together for the programs like Anemia Mukt Bharat, which is really brought down by the policymakers, so that we aim at ensuring the healthy society to make the citizens more healthy and more resourceful for the progress of the society. Thanks a lot, Dr. Hema, for giving me this opportunity.
Thank you, Dr. Pushpalata. Thank you, Dr. Keshamurthy sir. Should we take questions, or can we have the questions in the chat box since we are running late? Any questions can be posted in the chat box, and I think the faculty could answer them.
Yeah, we'll finish off the case presentations also. I think we are already behind
Yes.
12:15.
Yes. So we shall now move on to the panel discussion. Thank you very much, Dr. Keshamurthy sir and Dr. Pushpalata for chairing the session, and to all the faculty, Dr. Sunil Kumar, Dr. Manjappa, Dr. Yatish, and Dr. Shweta Nayak for a wonderful presentation. I would now like to introduce the moderator for our panel. So we have with us Dr. Annie Princey. Madam has spared her time today. She is an assistant professor in cardiology at Tamil Nadu Government Super Specialty Hospital in Chennai. And she has won various awards and has many publications and presentations to her name. So welcome, Dr. Annie. I would introduce the panelists also for Dr. Annie. We have the panelists. We have two cardiologists with us. Dr. Ashit Sridhar. Sir is a leading consultant cardiologist at Mangala Heart Care Center in Hassan, and is an expert in complex coronary interventions. Warm welcome to you, sir. Along with him, we have Dr. Balraju. Sir is an associate professor at Sri Jayadeva Institute in Bangalore, and is a senior consultant in interventional cardiology at Manipal Hospital, Bangalore. Sir is DNB from New Delhi with a gold medal and has participated in various trials as a principal investigator. We have from the obstetric side with us Dr. Priscilla Thomas. Madam is a consultant obstetrician at Moon Maternity Hospital in Hubli, and has been invited as a faculty at various conferences and has various national and international publications to her name. Joining her would be Dr. Sridevi Metgood. Madam is an associate professor at JNMC Belgaum, has a vast work experience, various research and trial publications, and has been awarded for the best paper at Kasoga 2012. From the anesthesia side, our support is Dr. Vijay Lakshmi. Madam is a professor in the Department of Anesthesiology at Mysuru Medical College and Research Institute. Ma'am is the president of ISA Mysuru City branch and has participated in various conferences, both national and international, and has various publications to her name. So once again, a warm welcome to all the panelists, and I would now hand over to Dr. Annie Princey to conduct the panel. Thank you.
So a very blessed Sunday to one and all. So it is indeed a great privilege to be among each one of you. So as we are running late, I'll just quickly move into the panel discussion. So together with me are my panelists, and thank you, Hema ma'am, for introducing them. So today we have two cases for discussion: acute MI in pregnancy and pregnancy in pregnant women with pacemaker. So I thank Dr. Manjappa sir. So he has almost completed most of the questions that will be asked now. So I'll quickly move into the case. So we have a 29-year-old female, a primary gravida. She's 32 weeks of gestation. She has been continuing her regular antenatal checkup in a primary health center. And she has gestational diabetes, which requires insulin for her treatment, and hypothyroidism on 150 micrograms of thyroxine. So the patient presented to our ED with a complaint of chest pain, which was acute in onset, compressive in nature with a time window of 3 hours, and associated with diaphoresis and palpitation. Her pulse state, she was a little tachycardic and tachypneic with BP on the lower side 90-60, and there was no murmur on auscultation or any crips. So I'll stop here. So with this background, so we have a primary gravida with 32 weeks of gestation. So in this background, I would like to ask the cardiologist to enumerate what would be the differential diagnosis at this particular scenario. Dr. Balraj sir. Am I audible?
Yes, ma'am, you're audible.
Thank you. Or Ashish sir?
Yes, I'm audible.
Yes, yes, sir.
Good evening, good afternoon, esteemed faculty. I will straight away jump to the question here. So we have a 32-year-old pregnant female with an acute onset chest pain. Of course, without any other thing, the first thing what we should be considering is an acute myocardial infarction for the prognosis it has. It has to be the first differential diagnosis what we should be looking at. Apart from the acute myocardial infarction or a pregnancy-associated myocardial infarction, that is what we would like to use the term now. We call it a pregnancy-associated myocardial infarction. The second thing would be an aortic dissection. Third thing would be acute pulmonary embolism, of course. And then comes all this, musculoskeletal disorders or esophageal reflux disorders. But the first three things should be pregnancy-associated myocardial infarction, acute aortic dissections, and acute pulmonary embolism. Thank you.
Thank you so much, sir. So can you also enumerate the things that we need to do, sir?
Can you come back again?
The first line investigations that need to be ordered.
Of course, the first thing that should be done is an ECG to see if there is any ST elevation MI or if there is any new onset Q waves or a left bundle branch block or significant STT changes. That is the first thing what we should be looking at. Second thing is we should be looking at cardiac biomarkers. In pregnancy, the cardiac biomarkers, we have predominantly cardiac troponins and CKMB, of course. The CKMB has low sensitivity and specificity issues because of the pregnancy per se can lead to elevation of CKMBs, but cardiac troponins are still sensitive and very specific. However, in a setting of pre-eclampsia or eclampsia, the troponins can give a false positive, but the next should be the cardiac biomarkers. If the cardiac biomarkers is positive in a setting of pre-eclampsia or eclampsia, a serial monitoring, a HS-troponin to be monitored over a gap of 2 years, or a regular cardiac troponin to be monitored over a period of 6 hours is what we should be looking at, followed by, of course, an echocardiography. Echocardiography, what we should be looking at is any wall motion abnormalities. How was the LV ejection fraction? Is there any other non-myocardial infarction etiologies which could explain, for example, Takotsubo cardiomyopathy or stress cardiomyopathy, which is also common in pregnancy. And if there is any indication of acute valvular complications such as an acute mitral regurgitation, acute aortic regurgitation, to see if there is an aortic dissection or aortic regurgitation. These are the three things that we should be considering immediately.
Thank you so much, sir. So this question I would like to ask to Sridevi ma'am. So ma'am,
Yes.
what is the most common cause of chest pain in a pregnant woman? So leave
Yeah, so any woman coming to the antenatal clinic with evidence of chest pain, we usually think of the non-myocardial causes. But yeah, after listening to this webinar, I think, yes, we should consider the differential diagnosis of myocardial infarction. But in my practice, what I have seen so far, most commonly, it is the gastroesophageal reflux, ma'am. So most of the women, because of the high levels of progesterone in pregnancy, they tend to have gastroesophageal reflux, and most of them, they do respond to anti-acidity drugs, those kind of things. But yes, definitely, if it is an acute onset chest pain where the patient doesn't look to be having some benign cause, we should encourage them to go ahead with evaluation for cardiac causes with an ECG, echo, and all the cardiac biomarkers. The other thing would be pre-eclampsia. I mean, imminent signs of eclampsia. Sometimes I have seen a couple of patients presenting with acute onset chest pain, and it was an imminent eclampsia. So we have considered those. And some cases like even peripartum cardiomyopathy, along with breathlessness, some of the patients have presented with chest pain. Yes.
Very true, ma'am. So this is what has summarized. So the differential diagnosis of chest pain. So we need to evaluate whether it is a stress, exertion, or during respiratory variation. So if it's going to be a test, we need to evaluate what is the character of the pain. If the steering, suspect aortic dissection. If ECG changes are there, consider acute coronary syndrome, pulmonary embolism. If it is associated with respiration, respiratory like pneumothorax, etc. So as madam has told, the most important concept is ERD, and it can stay any time during pregnancy. But as Manjapa sir has told, cardiovascular causes like acute MS is more common during the third trimester. So I would like to revise that this patient is belonging to the third trimester, acute onset chest pain, and a compressive nature. So the investigations, like as Balraj sir has told, ECG, biomarkers, where troponin is more important, D-minus, echo, and CT imaging can be done to arrive at the diagnosis. So now I'll go to the case. So this is the ECG of a patient. So here we see ST elevation anterior beats with reciprocal changes. So other investigation that was done was RBS was high, hemoglobin was 9, HbA1c 7.2, and troponin was elevated. So now this brings us to what is called PAMI, pregnancy-associated myocardial infarction. So, sir, here I would like to ask Ashish sir, what would be the probable causes of this panning?
So, pregnancies or myocardial infarction, we can divide it into two groups. One is an obstructive coronary, and another is a non-obstructive coronary. In obstructive coronary, we have either an atherosclerotic plaque rupture causing either with a thrombotic or a non-thrombotic coronary occlusion, or it could be a spontaneous coronary artery dissection causing a complete obstruction of coronary. In a non-obstructive coronary flow, here also again it could be a partially ruptured atherosclerotic plaque causing a partially occluding vessel with the thrombus, or it could be a SCAD, spontaneous coronary artery dissection causing a non-flow limiting occlusion, or it could be a coronary vasospasm. These are the two categories what we should be considered: obstructive, non-obstructive. In non-obstructive also we can have atherothrombotic coronary occlusion, or it could be SCAD, or it could be a simple coronary vasospasm. Of course, here also it comes, there is another entity called Takotsubo cardiomyopathy or stress cardiomyopathy, which also has to be considered. In obstructive forms, we have two things: atherosclerotic thromboembolic occlusion of coronaries, or it could be a SCAD, which is causing total occlusion of the coronaries due to coronary artery dissection. Pregnancy being a hypercoagulable state, sometimes a embolism from different cardiac chambers can also cause an embolic cardiac coronary occlusion causing an MI. Sometimes a paradoxical embolism from a lower leg venous system can cross over from right atrium to left atrium in a patient with an ESD or a PF4 during Valsalva, and these can also cause myocardial infarctions.
Thank you so much, sir. So, summarizing, as sir has told, it can be either an obstructive or a dissection and other causes. So, as you see, the plaque erosion with atherothrombosis, it accounts to about 35 to 55%. So, here I would like to stress that atheroembolism is still the most common, that is followed by SCAD. And then, as sir has told, in situ thrombosis, embolic, coronary vasospasm, and topicibus. So, there's another question, like whether there is any clinical clue to differentiate these. So in case the patient gives a history of a SCAD, a Marfan, a very high blood pressure, a fibromuscular dysplasia, other inflammatory diseases, sarcoidosis, substance abuse, these can raise a suspicion of SCAD. Also, even in the absence of anything else, SCAD should be suspected because 30 to 40% of acute MI occurs due to SCAD. So now moving into our case, so we did an echocardiogram. The patient showed a hyperkinesia of the anterior wall, anteroseptal, anterolateral segments, and the EF was 30%, moderate systolic dysfunction. There was a mild MR, no clot, no pericardial effusion. So we'll stop here again. So now I would like to bring the obstetrician to the scenario. So here we have 32 weeks pregnant women with acute myocardial infarction. So we still don't know the cause. No, so I call upon Sridevi ma'am, to give us what are the precautions that you would like to take to the cardiologist, what evaluations will be done at this present to the fetal and maternal safety.
Okay, ma'am. This patient, suspecting that it could be a myocardial infarction, we need to confirm the diagnosis with an ECG, echo, and the cardiac biomarkers. After we do that, then according to all the literature, the first thing that has to be done is a percutaneous coronary intervention. That's the one which is the standard of treatment for most of the cases of myocardial infarction in pregnancy. So I would discuss with the cardiologist. I would advise that. Also along with that, I would also do an ultrasound for the fetal viability to look at whether the fetus is viable or not. And if it is so, then I would consider giving antenatal corticosteroids. And after discussion with the cardiologist, I would, advise or rather discuss and tell him to do a radial angio for this patient. Most of the times, most of these patients, they may require just a thrombus aspiration or just a balloon, POBA. But in most of the cases, there is an increased risk of abruptio placenta. So when they give them high doses of thrombolytic agents, then the attenders have to be counseled about the risk of abruption and sudden IUD. I would also plan for delivery as soon as possible because in our setting, we have a very good NICU backup. So even at a 32-week fetus would be salvageable. So in case there is requirement, then I would go ahead and deliver the patient. And adequate arrangement for blood and blood products also has to be done for this patient.
Thank you so much, ma'am. So fetal assessment, a prior plan for delivery, reservation of the blood and blood products, anticipating complications. So this would be the obstetrician part of it.
Let me just add on, ma'am. In the fetal evaluation, when we do an ultrasound, a fetal Doppler is also a requirement because that helps us to decide if in case we are delivering at the earliest, that gives us a good feedback to the neonatologist. So anticipating asphyxia in the neonate.
So now I would like to ask the cardiologist. So here we have diagnosed the patient to be an acute myocardial infarctions. So what will be the line of management? What would you choose? A conservative, thrombolysis, or an invasive one?
All right. So let me take this question.
Yes, sir. Yes, sir. Sure.
Yes. So here we have a female who is having an ST elevation MI, and hemodynamically she is a little bit unstable. The blood pressure is also on the lower side. The conservative strategy is restricted for non-ST segment elevation MI without high-risk factors. The high-risk factors being patient's hemodynamic stability, not having a refractory angina, electrically patient is stable, that is the patient doesn't have any arrhythmias, echo does not show any complications such as ischemic myocardial mitral regurgitation or a severe ventricular failure. If none of these high-risk features are there in an STEMI, we can consider a conservative management. But otherwise, ST segment elevation MI and high-risk STEMI, just like any non-pregnant woman, the primary therapy to be offered is a primary coronary intervention. Now, which is the type of what is the type of coronary intervention? What we do depends on the angiographic findings. We would definitely take the patient to angiography as early as possible without wasting much of the time. As far as whether it is a femoral angioplasty or a radial angioplasty, I am a predominantly radial operator. 95% of our cases nowadays we do with the radial. But I think the literature shows that both in terms of the fetal radiation, the time taken for the procedure, and in pregnancies generally, the femoral approach is better. It is not due to it's mostly due to technical reasons because 30 to 40% of these patients will have SCAD. And SCAD is seen more often in left main vessels and left anterdescending artery. And when the radial guide engages, it's a very active engagement with abrupt engagement of left main. The spontaneous dissection might progress, might worsen. So from a pure technical point of view, we usually go from a femoral route and we do an angiography. If the angiography shows a totally occluding obstructive coronary flow, whether it is due to thrombus or dissection. In a thrombus, of course, the first thing would be to do a thrombus aspiration with or without a balloon angioplasty. That is suffice. We generally want to defer stenting in pregnant females. But however, if you are unable to defer stenting, if the flow in the coronaries are not in the expected level, if there is no TIMI3 flow achieved, then we would rather go ahead and put a drug-eluting stent. There was some amount of debate regarding a bare metal stent and a drug-eluting stent. But in the era of newer drug-eluting stents with the short-term antiplatelet needed, dual antiplatelet, it's what we call DAPT. A short DAPT is more than suffice in many of these newer generation drug-eluting stents. So if the thrombus aspiration and balloon angioplasty is not suffice to give a good TIMI3 flow in the coronaries, we would still go ahead and deploy a drug-eluting stent. If the patient is having a SCAD or a spontaneous coronary dissection, now it becomes a little bit more difficult. In terms of the outcomes with the primary coronary intervention in SCAD, generally the results are not great. The mortality and the prognosis have not been significantly different in both stented and non-stented patients. However, the establishing TIMI3 flow is of primary importance. Establishing a normal flow in coronary is of prime importance here. So in a situation where we have to stent it, we usually go for a long stents where we cover a stent from a normal area proximally and a normal area distally, covering a complete amount of the dissected areas. However, before putting a stent in these kind of situations, we would like to use imaging modalities in terms of either an intravascular ultrasound or an OCT. These imaging modalities, two things it will help us. One is it assures us that the wire is in a true lumen and not in a dissected false lumen. Second thing, it helps us in sizing and determining the normal areas where we want to stent from a normal to a normal area, so that the progression of dissection is kind of limited, or at least it is prevented. Another thing is that we generally use a cutting balloon here, where we try to cut open the dissected plaques and create a more and more dissection, so that the hematoma, either it is compressed or there will be re-entry from a dissected plaque. It's more of a technical point where you use a cutting balloon, open the dissected fragments or plaques, reduce the intramural hematoma, put a stent from normal area to normal area, establish a TIMI3 flow. This is what we follow. If angiography doesn't show a flow limiting lesion, suppose there is a normal flow, but it is causing a 40-50% obstruction or 50-60% obstruction, in these kind of situations, we would manage them conservatively with anticoagulations and antiplatelets rather than stenting it.
So thank you, sir. Ashit sir has finished everything. So here, I would like to just summarize the thrombolysis has been done in panel. So since atherosclerosis is a major cause, thrombolysis is not actually an absolute contraindication. Streptokinase can be used because it has a lower rate. As sir has told, similar to any other non-pregnant, taking in primary birthday is a main thing. So summarizing the line of management, so the management depends upon the extent of the SCAD, the location of the SCAD, the clinical presentation, and the hemodynamic status. So the hemodynamic status plays a very important role. So that will determine what we are going to pursue. So coming to diagnostic angiography, that is what Saul was telling. So sometimes we have a like whether it is like a risk to the fetus, we have the telling, but it is diagnostic coronary angiography has an acceptable risk. The fetal radiation is less than 50 millisieverts, and fetal radiation dose associated with CAG is less than 1, and risk of radiation to the fetus is likely negligible. However, we can reduce the fetal radiation dose by using a radial route, a short fluoroscopy time, a low frame rate, and minimizing the semi-angiography. So to our patient, we loaded the patient, we gave anticoagulant, and we shifted her to the cath lab. So this was the coronary angiogram. So as all of us suspected, so this was a SCAD in the middle lady. So sir has told about intracoronary imaging. Sir told that he'll opt for intracoronary imaging. That is very important to know about the extent of the SCAD and how we are going to place the stent. So all this is very, very important. But a caution is that you need to remember that the imaging modalities do have potential. We can extend the dissections. So guide catheter hydrogenic dissections can be caused. Catheter-induced occlusion can be caused. And all these has to be kept in mind before using this. So one more question I would like to ask the cardiologist, probably Balraj sir. What is the role of CTVS here? When will you call a CT surgeon?
CT surgeons are called when you are dealing with an either a significant LM lesion or proximal vessel occlusion. The issue with the CTVS people is even if they undergo bypass grafting, these scats are known for spontaneous healing takes place over a period of time, and they can undergo grafting, but over the period of time, the competitive flow once the vessel opens up, the possibility of grafts are getting closed are very high. So until you're dealing with an life-threatening complication or hemodynamic complication or LM occlusion or maybe an LM dissection, usually we don't call for an CTVS opinion or a CTVS call in these kind of cases. Except for LM, I don't see any flowing vessels, whether the proximal LAD or proximals are, if the vessels are flowing at least timid 2 to 3 flow, I think over the period of time with an heparin and DAPT, the flow will get naturally, established, and intramural hematoma IMH will also come down. So I'm quite skeptical about, calling the CTVS opinion. Yeah.
Yes, sir. Rightly mentioned. So as sir has told, the SCAD, it heals by itself over time. There are two important indications when the role of CTVS comes into picture. So the left main dissection and the patient is hemodynamically compromised or a severe multi-vessel dissections. So here, so this is a summary. So if the patient is clinically stable and no high-risk anatomy such as a left main dissection or more than 2-vessel dissection, you can place the patient in conservative therapy. So if the patient is clinically stable with a left main and a severe proximal dissection, you can consider a CABG or as a conservative management. And if there's an ongoing ischemia or hemodynamic instability, so consider PCI or an urgent CABG. So this will be the management plan. So here we did a PCI to this patient. So there was a successful stenting with a TIM-free flow, and luckily, and post discharge, we followed up the patient for 34 weeks. She was asymptomatic. Repeat echo showed an improved LVEF of 45%. Medication she was on aspirin, clopidogrel, and atorvastatin. So now I would like the obstetrician to enumerate the effects on the fetus of the stent and also the statins. So ma'am, what would be your thoughts? So we are placing the patient having the stent inside. What would be the fetal outcome?
One thing is, ma'am, during the procedure, the fetal heart rate monitoring should be done. Now, in this case, she was 32 weeks. So it's a viable fetus. And, in case of any hemodynamic instability leading to fetal distress, that would warrant immediate delivery. So a continuous fetal monitoring during the procedure. And once, like in your case, the procedure went well, the fetal heart rate being normal, it can be followed up with serial ultrasound, probably the fetal Doppler, to just check in that there is no resistance or there's no alteration in the fetal circulation. That is one thing. And regarding the medicines, we have very less literature in obstetrics regarding statins, use of statins. Aspirin, clopidogrel, they're all well safe in pregnancies and they don't have any fetal effects. And like Sir did mention about the bare metal stents and the DES stents. In our OBG literatures, we do not have much literature regarding the effects of stents. And in all the cardiology papers, it does says that the bare metal stents are effective. But then in this case, she is near term, 32 weeks delivery. The effect of DES stents on the fetus is little less rare. So whatever is best for the patient would be a DES stents as the cardiologist would suggest it.
Thank you, ma'am. So, like the effect of stents. So, antiproliferative drugs used for coating the stents, they are relatively safe because only a small quantity of it is released. So, there's only a local effect and no systemic effect on the fetus. So, similarly, there is a paradigm shift in the use of statins in pregnancy. So, this is one study which shows that the overall treatment with statins during pregnancy is not associated with increased risk of congenital anomalies. So previously, statins was a category X drug and it was contraindicated during pregnancy. But as we all discussed, there is an increase in coronary artery disease during pregnancy and CAD causes more mortality, maternal mortality, and therefore statins can be given during pregnancy. So coming to the antenatal follow-up, the patient has to be actively monitored. In third trimester, the anesthetist comes into the picture. And as Manjapa sir has told, 2 to 3 weeks, it is very important that we do the pregnancy because we can manage and stabilize the patient. So here I come back to my place. We had a multidisciplinary team approach and the patient was admitted at 36 weeks. We did a re-evaluation echo and as I mentioned, there was a mild hypokinesia. There was improvement in the LV function to 45%. There was only a trivial MR. So now here we have, so I would like to ask the obstetricians, like what will be the mode of delivery that you would like to proceed and how will you manage DAPT? And I would also like to ask Dr. Vijayalakshmi ma'am, what are the anesthetic concerns that she has with DAPT in case the patient proceeds in for an LICS?
Shall I take it? So, good afternoon, everyone. So, I thank Sushma team for their wonderful session. So, it is my privilege to be part of this session. So, coming to my question, so what are my concerns during this? In this case scenario, our parturient who is on dual antiplatelet therapy, she has posted for elective vaginal delivery as per this case report. So, if at all, if it is for elective vaginal delivery, as per the recommendations, the dual antiplatelet therapy to be converted to single antiplatelet therapy by stopping the clopidogrel 7 days prior to the labor, induction of the labor, and continuing the aspirin. So, as we have stopped the clopidogrel and continuing the aspirin, now we can definitely she is the case for the labor analgesia. So, labor analgesia is definitely indicated in this parturient in order to control the increase in the heart rate and also to control the blood pressure, which are as because of increased sympathetic stimulation in response to labor pain. So, controlling the heart rate is much important here because the increase in the heart rate affects both the fetus by affecting the uteroplacental blood flow, and also it is very detrimental for mother. So because the heart rate is the one thing which comes under both demand and supply. So increase in the heart rate increases the demand by increasing the myocardial contractility. At the same time, it decreases the supply by decreasing the diastolic filling time, thereby and diastolic volume. So coronary perfusion will get affected. So controlling the heart rate during the labor is at most. So for that, it is definitely this parturient is the definitely case for labor analgesia. And regarding the labor analgesia, our choice of labor analgesia for this patient is continuous epidural with intermittent boluses. So that is preferred technique. So here the continuous epidural injection with very low concentration of local anesthetics. That is usually what we prefer is 0.06225% to 0.125% of either bupivacaine or levobupivacaine or ropivacaine, along with fentanyl 2 microgram per ml So at a rate of 8 to 15 ml per hour, it will be given as a continuous epidural infusion. So this will be usually followed by intermittent bolus of 5 to 10 ml of the same mixture. So whenever it is required in order to overcome the breakthrough pain. So this actually, there are certain advancement in the maintenance of this labor analgesia. So these are like, so patient control epidural analgesia we do have. So where the patient herself controls her pain. So whenever it is required, and we have a programmed intermittent epidural boluses, and also so computer integrated program, patient control epidural analgesia. It is a novel delivery system in which so this computer automatically adjusts the background of infusion rate. Suppose, if the, it is definitely based on the parturient demand. So suppose in the previous hour, only when parturient demands only for once, so the infusion rate will be just 5 ml per hour. If she takes 2 times, if it is there any record that she has taken 2 boluses, so then it will be increased to 10 ml. So the computer itself adjusts the infusion rate. This is one thing. So that is called a CIPCA, that is computer integrated patient control epidural analgesia. So this is regarding when the parturient is posted for elective vaginal delivery. Suppose the same parturient has come for emergency vaginal delivery, which is not planned. So since this parturient is on dual antiplatelet therapy, here there is no scope for regional anesthetic technique even for the labor analgesia. It is contraindicated because of concerns regarding dual antiplatelet therapy. So in this case, we should definitely plan for non-regional pharmacological labor analgesia like inhalation agents like Entonox. So it is the good old drug. So it is 50% nitrous oxide, 50% oxygen. So patient, the participant has to inhale, anticipating her contractions at least 50 to 30 seconds before her contractions. Another important and another very commonly used is Sevenox, that is the mixture of oxygen and sevoflurane at the percentage of 0.8%. Sevoflurane at 0.8% is being used for a very good labor pain relief. So apart from inhalation agents, systemic analgesic like remifentanil, fentanyl opioids, especially the remifentanil. So it is a very short, ultra short acting. So it is used because of its rapid action and the short duration of action. It is used as a patient-controlled intravenous analgesia at the dose of 0.25 microgram per kg body weight with the locking period of 2 minutes over the background of infusion of 0.025 to 0.1 microgram per kg. This is regarding the labor analgesia. When this patient, the same patient, if she lands up with failed induction coming for the emergency LSCS, so if it is patient is on dual antiplatelet therapy, there is no question of again regional anesthesia. We would like to go for general endotracheal anesthesia with rapid sequence induction with most like etomidate and docuronium. And if at all, if this patient comes for elective cesarean section, that means that's clopidogrel has been stopped earlier, 7 days earlier. So then we can still go for regional anesthesia technique like sequential combined spinal epidural. So where we use very low dose of intrathecal opioids and very low dose of intrathecal local anesthetics like bupivacaine with intrathecal opioid. So this is the preferred technique. So, and the monitoring during the anesthesia is at most, important, whether it is for labor analgesia or for the section. So we need to monitor intensively these patients. So they need IABP, so beat to beat variations in the blood pressure to be monitored, the heart rate. So our goal is to maintain the heart rate. So optimization of the preload, afterload, and myocardial contractility, and the good analgesia. All these are very much required if it is available. So TE is the best monitor. So and meticulous management of the fluid status is very, very important because there will be in the edge slight increase in the preload will end up with pulmonary edema. So that is also very judicial management of the fluid is also very important.
Thank you, ma'am. That was a beautiful elaboration. So summarizing it, so the optimal mode of delivery depends upon the patient's cardiac functions and presence of concurrent conditions like associated malformations or iotopathies, etc., which would have been associated with coronary dissection. So if the patient is a hemodynamically stable one, recovered cardiac function, assisted vaginal is advised, and the patient is unstable hemodynamics and high-risk obstetric indications or high-risk patients, cesarean can be done. So coming to peripartum antiplatelet management, Madam has elaborated, clopidogrel can be stopped 5 days prior to elective LSCS, but low dose aspirin can be continued. So the duration can be shortened up to 4 weeks, particularly if there's a large thrombotic burden. Delivery may be postponed to 2 weeks post-MI. And in patients with pregnancy that was not undergone stent, SABT is recommended. So to coming to this patient, she was admitted at 36 weeks. She was in IHA function class 1 with a EF of 45%. She was delivered vaginally. She had an extended ICU care for monitoring, and patient was asymptomatic upon discharge and follow-up. So then the patient was advised to come for periodic follow-up until 6 weeks. She was referred to cardiology for registration and follow-up with the cardiologist. The medications patient was on aspirin, clopidogrel, and atorvastatin. Now the patient, before leaving, she wants to know whether she can have a subsequent pregnancy. So now I ask the obstetricians, Priscilla ma'am and Sridevi ma'am, what is the contraception that you would advise to this patient and whether she can undergo a subsequent pregnancy?
Yes, she should be given a chance for a subsequent pregnancy, but then yes, there should be minimal gapping of 3 to 4 years. The contraception that she can be eligible is non-hormonal methods, because the hormonal contraceptives or the injections, DMPS, are absolute contraindication because of the high estrogen and progesterone status, which can lead to embolism. So the most common used non-hormonal methods would be a copper T insertion. Now that we have the multi-load devices which come with very less side effects, so that would be the safest contraception that we can offer her.
Yes, ma'am. Absolutely. Yeah. And also, because the patient would be on anticoagulants, there is a risk of menorrhagia in these patients when we're using a copper T or, other methods, barrier methods or something like that. So another option would be to give a LNG IUS that would act locally, so without any systemic side effects of progesterone. So even LNG IUS can be considered for a contraception purpose in such patients.
Thank you so much, ma'am.
Yeah.
So your opinion on subsequent pregnancy, ma'am?
If her hemodynamic status remains normal and her stent remains, active, there is no shifts in the stent or yes, she can have a planned pregnancy with a proper prior preconceptional cardiac evaluation.
Yes, and she would also has to be counseled that there is a risk of recurrent ischemia and reinfarction in the subsequent pregnancies. And in case she is on statins and she conceives accidentally, there is no need to terminate the pregnancy, the subsequent pregnancy. In such a woman, because now, of course, the hydrophilic statins are found to be safe in pregnancy than the lipophilic statins. So we should consider these kind of statins whenever we are considering any chance of future pregnancies in women with myocardial infarction.
Thank you, ma'am. Rightly said. So the subsequent pregnancy depends upon the primary cause and what is her LV function. So if it is going to be a severe LV function and if it is going to be a SCAD, the recurrence rate of SCAD may be there in the subsequent pregnancy, and a patient with severe LV dysfunction, she belongs to MWHO class 4. So other than that, as Priscilla ma'am and Sridevi ma'am told, so we can allow the pregnancy in a monitored way. So next we'll move into the second case, pregnancy in a woman with pacemaker. So here we had a 23-year-old female who's a known case of congenital complete heart block. She was given a pacemaker implantation. It was done 2 years back. She is in periodic follow-up with us. She presented to our OPD with concerns of proceeding with conception. So we're just married and she wants to proceed with pregnancy. So I would like to ask the OGCNs, so what is the type of pre-pregnancy counseling that you will give to this patient who's on pacemaker? Cardiac OGCNs. Am I audible?
Yes, ma'am, you're audible. We can hear you.
What is the type of preconceptional counseling that will be given to this patient, ma'am?
The preconceptional counseling with the patient who's already on a permanent pacemaker, in case if she has any structural defects or this was, heart block, she should be made aware that there is a chance of increased fetal risk of having congenital cardiac anomalies. The risk fold increases 2 to 3 times than the general population. So a concern regarding the screening for congenital cardiac anomalies and being made aware of it should be told. But it is also the same time that there is, whatever anomaly the mother had, it is not mandatory that it is going to be repeated in the fetus. She should be rest assured that, a screening should help us detect something, but then it is not mandatory that the fetus is also at risk.
Thank you, ma'am. So summing it up, so evaluation for congenital anomalies in the fetus, genetic counseling, assessment of the cardiac function and functionality of the pacemaker. So all this should be a part of preconceptional counseling. So this is a picture showing the DDD. So here you have a atrial lead and a ventricular lead. So now the patient, she presents again to us after confirmation of pregnancy, referred to the obstetrician to us, and she was referred for cardiac evaluation or opinion regarding continuation of pregnancy. So I would like the cardiologist to just give us the opinion as to whether to continue the pregnancy and how will you risk stratify her. Dr. Balraj, sir?
Yeah. This patient is as good as any other normal person. Despite having a pacemaker, we have to make sure that the pacemaker interrogation is being done and look into the LV and RV function. Basically, the late onset of LV dysfunction with this pacemaker is quite common. And look into the battery life, which is how much battery life is spending with the given pacemaker. These are the two things to be looked in a given patient. Apart from that, we have to tell the patient that this is what happened and watch for some symptoms, especially syncope or palpitation, which may be, maybe part of the pregnancy or maybe pacemaker induced. That those symptoms has to be monitored, or else pacemaker should not deny, or we should not would say negatively counsel them regarding the outcomes, especially with the pacemaker. With the DDDR pacemaker, I don't think so there will be any issues.
Yes, sir, rightly mentioned. So according to MWHO, we have arrhythmias classified, but conduction defects are not being classified. But according to the MPAC study that was published in 2023, so congenital complete heart block asymptomatic, they belong to the low risk, and patients with pacemaker, they belong to low risk. So as rightly pointed out, we should not deny pregnancy in these patients. So I'll come to the patient story. So 24 years female, primary gravida, 8 weeks of gestation, status was permanent pacemaker implantation. Now she's asymptomatic, NIHA class 1. Pulse rate was 60, BP was 160, and other evaluations were found to be normal. This is a ECG. Her echo was normal. You can see the lead rightly positioned. And now, so I would like to ask the obstetricians and cardiologists. So this is an interrogation strip. So what are to be monitored during pregnancy? So one point that sir has told that you have to monitor for any symptoms. So the symptomatology of the patient, whether there's any palpitation, breathlessness, syncope, seizure-like activity, dizziness. Secondly, we need to monitor the ECG. Third one is we need to find out whether the patient is totally pacemaker dependent. So that will depend upon the device interrogation. So pacemaker dependent patients, one thing is important is we have to be extra cautious during surgery. So I will just proceed with the antenatal follow-up of the patient. She had an uneventful antenatal period. So these were her pacing parameters. And now let me come to this part. So this is one important thing I want to discuss. I would like to ask the cardiologist, what are the necessary precautions that you will advise in case the patient proceeds for LSCS? And to the obstetricians, what will be the mode of delivery?
Shall I?
The mode of
Yes, sir. Go ahead.
I think Priscilla ma'am, you can start first, ma'am, so that
the mode of delivery, since it's a pacemaker and the parameters would be set without fluctuation, the mode of delivery would depend on the obstetric indication. So she is eligible for a vaginal delivery, and in case if there's an obstetric need, only then an elective cesarean section. And in cases of vaginal delivery, we make sure that the maternal heart rate is also monitored along with the fetal heart rate. And an assisted vaginal delivery would be more first to avoid the extra stress of generally obstetricians, we do use cautery, and most of the time we use a monopolar cautery in cesarean section. So in a case of permanent pacemaker, it is always advisable that we change over to a bipolar cautery, and give a concern to us, whereas where is the patient plate attached. I think this is the special care that we take when we have a case of pacemaker, and keep our cardiologist informed, and give the trouble to be them in our OT.
Thank you, ma'am. Sir?
Yeah, nowadays the pacemaker, whatever DDR, everybody says if you are doing any surgery below diaphragm, no need to change the mode. But to be on safer side, if the patient is, if the patient dependency is high on the pacemaker, better you go to VVO mode, bring the guy, plan your procedure, make it elective procedure, bring the technician, change to, asynchronous continuous spacing, VVO mode, and do the surgery. When the surgery is done, you go back to the previous mode. One. Second, when it comes to the cautery, I think they are the experts. They say bipolar cautery. Still, if the below diaphragm surgery, still you can use, they say use minimal cautery. Nowadays, below diaphragm, any cautery won't affect your pacemaker. Apart from that, that's all. Yeah.
So, thank you.
Since there is no concern from the cardiologist side, should we still go to their OT? I don't think so, right?
No. The company fellow will go, not the cardiologist.
So you, when it is a medical college setup where the departments are just upstairs and all, probably you would not be trouble. But definitely in a private practice like ours, where we work in a multidisciplinary team, we would trouble our cardiologist to be at least in our changing room, be there as standby.
No, it's our pleasure to be there in the labor ward.
I kind of see a sarcasm in his words, but I take your point, ma'am.
Thank you.
But generally, what we meant is it's a very, very safe process. The pacemaker should really not make a difference between a normal pregnant lady's management with a pregnant lady with a pacemaker. On the contrary, it's probably much safer if there is any vasovagal or anything that happens to a normal pregnant lady or unprotected, but in a lady with a pacemaker, even a vasovagal is also kind of protected. So it's probably much more safer than a lady without pacemaker.
Thank you, sir. Thank you for bringing that out. So as mode of delivery, as it was discussed, it was delivered vaginally, and mode of delivery, any obstetric indication, you can proceed for LSES. Now the precautions, I'll just summarize. So you minimize the use of bipolar cautery. So this is because the cautery produces a noise that will interfere with the EMI of the pacemaker. So it will affect the pacemaker output and it will reset the pacemaker. So you can, next thing you can do is, as sir mentioned, you can change it into DOO mode. So you can place a magnet and you can reset it into asynchronous mode. And then the grounding plate should be nearest to the operator and should be farthest from the pacemaker. So now coming to this patient, she was admitted at 36 weeks. On admission, she was NIHA class, it was 1. And her vitals were stable and patient was vaginally delivered and labor induction was done. Planned for a vaginal delivery. Labor induction was done, but it failed. And so she was taken up for LSES. So the cardio team, as madam wanted, we were present during the LSES. The use of cautery was minimized. Procedure was uneventful. Patient was normally pacing and she was observed in the ICU. So pre-discharge, patient was asymptomatic. We did an interrogation before discharge and patient was advised to get follow-up in cardiology. So I've taken, I would like to thank the cardio obstetric master classes. So this, we are doing it every second Friday. We request you to join us, all the panelists and the speakers of today. So it was really wonderful to be a part of this. And I have borrowed some of the key messages from the cardio obstetric master classes that we do. So ending this up, so PAMI is a challenging one to treat. It requires a multidisciplinary team, and acute chest pain, significant ECG and markedly raised biomarkers should raise suspicion of PAMI. The etiology may be due to atherosclerosis 1/3, as I told, and SCAD in 1/3. And primary PCA is preferred over fibrinolysis. So this we have to keep in mind. Wherever PCA is capable, you just take the patient for primary PCA. And then this patient has to be managed similar to a non-pregnant MI patient. Aspirin should be administered in all patients. Clopidogrel and heparin should be preferred to other drugs. Beta blockers is safe. RAS inhibitors should be avoided. And PAMI due to SCAD, conservative approach is preferred. Revascularization is indicated when the patient is hemodynamically unstable, and CABG can be considered if the patient has a left main or a proximal 2-vessel SCAD. And DAPT with aspirin clopidogrel can be continued during PCI, those who have undergone PCI, SAPT if no PCI, and postpone the delivery at least 2 weeks post-MI whenever possible. Normal vaginal delivery is preferred mode of delivery. and clopidogrel should be stopped 7 days prior to delivery, and bridging, if needed, can be used during anesthesia. And subsequent pregnancy, as I told, should be considered only after 12 months. And if the patient is scared, you can avoid subsequent pregnancy. Individualized counseling should be offered. So coming to a pacemaker patient, so pregnancy in patient with pacemaker is not a contraindication, but still it requires a multidisciplinary approach. Normal physiological changes in pregnancy may necessitate antenatal pacemaker adjustment. Pacemaker dependency should be recognized early in pregnancy. That will help us to plan, and periodic follow-up is necessary. And the route of delivery is generally based on obstetric indication. During surgery, bipolar cartridge should be used to reduce electromagnetic interferences, and grounding pads should be placed far away. Following pregnancy, so you need to follow up the patient. You have to make sure that the baseline cardiac status and the pacemaker settings are adjusted accordingly. So this brings an end to our panel discussion. I thank one and all.
Thank you, ma'am. That was a good discussion.
Thank you.
Thank you.
Thank you, Dr. Annie Princey, for a wonderful panel discussion, and a large, warm thank you to all the panelists also, Dr. Ashit, Dr. Priscilla Thomas, Dr. Vijay Lakshmi, ma'am, and all the other panelists for making this panel a successful one. Dr. Balraj sir, as well as Dr. Sridevi Medgood ma'am, you made time, and I know the proceedings overshot the time, but still we managed to have a very fruitful discussion. Dr. Prakash Mehta is joining us, the president of SMFMI, and he would like to give a few concluding remarks. Sir has joined.
Meanwhile, before Sir joins, and indeed it was a great extensive panel discussions on the rare topics which are most often not covered, especially the pacemakers and the MI and IHDs. The discussions were extremely well, and thanks to all the panelists and of course the moderator for bringing in very informative discussions. Thank you everyone. We have our president, Dr. Prakash Mehta sir, joining us from Bangalore.
Yeah.
Prakash,
Good
sir,
afternoon,
over to you.
everybody. Well, right now I'm in Mumbai. Anyway, what a wonderful program the Mysuru Society has arranged. I think we have to thank both Dr. Sushma and Dr. Hemapriya for bringing this particular topic out in the open. We all know that the cardiac disease is changing its character over the last few years. From a time when we were dealing with only rheumatic heart disease, we have moved over to where we have the mitral valve replacements already done, or we have more of congenital defects as well as the myocardial infarction coming in. I think this is a very good attempt to try making everyone aware of the cardiac problems in pregnancy. And I'm very sure that the Mysore branch will keep on doing such wonderful work over and over again in the next few years. So thank you, Dr. Sushma, Dr. Hemapriya, for arranging this kind of a program. And hope that you will arrange more such programs in future so that all our doctors benefit. And thank you very much for inviting me to be a part of this program. Thank you.
Thank you. Thank you so much, sir. Sir has always been a mastermind behind all our ventures. And thank you for all your encouraging words, sir. And definitely we will follow your advice and follow your path. Thank you so much. Over
Thank
to
you.
Hema.
Thank you, sir, for your encouraging words. You have always been a mentor for us and guide us always. So please continue to do that, sir. And I would like to thank all our faculty who joined us today. Our chief guest, Dr. Charmila Madam, guest of honor, Dr. Kasturi Donimat, for their encouraging words. Our chairpersons, Dr. Keshamurthy sir and Dr. Pushpalata, who did a wonderful job of moderating the sessions, as well as all our speakers, Dr. Sunil Kumar, Dr. Manjappa, Dr. Yatish, and Dr. Shweta Nayak. Our panelists, moderator, Dr. Annie Princey, at the last moment, she put up 2 wonderful cases, and we had a very enlightening discussion with the panel. And all our panelists, Dr. Vijay Lakshmi ma'am, Dr. Priscilla Thomas, Dr. Sridevi ma'am, Dr. Ashit, and Dr. Balraj, for contributing their valuable inputs. I would also like to thank all our audience, our students, our postgraduates who have been religiously attending our series of webinars. And finally, the MCure Inventia division, who provided us with the technical support, the RX events, who have provided the platform and who have organized this event seamlessly throughout the 2 months. And we have had wonderful feedback from our students as well as our colleagues. And all the videos are there on YouTube. The recordings are available on YouTube, so everybody can make the most of this. So thank you very much. And we would like to conclude the session here. Sushma, any closing remarks you have?
Yeah, at this tenure, we sincerely thank especially Mehta sir and our parent organization of SMFMI and my fellow colleagues, and the very active Hemapriya being the secretary and a team of EC members. And of course, our big venture of inviting other specialty, primarily all the senior cardiologists who have been part of our 3 webinar series over 2 months. We have had a great discussions from the early trimester cardiac complications to the second trimester labor, and of course the today's crisis discussions. And each sessions, the very senior and eminent faculties are being part of our webinar series, and all the sessions have been thoroughly enlightening, and it has added a lot of inputs and knowledge into the obstetric practice. And we really wish to have a continuous sessions in similar way with the other specialties. And because the key to reducing the MMR globally is the multidisciplinary approach, and of course all the specialties should put together and work for the safety of the motherhood. And we look forward to enhanced supports, and it's a great gratitude from our Society of SMFMI Mysuru chapter. And we sincerely thank all the people who have been part of our webinar series, from the technical team to all the faculties and every person's, our own members, for being the great support to all of us. And we wish to continue several webinars and of course the CMEs in our subsequent days. Thank you everyone for joining us and for being the great force of encouragement for all of us. Thank you.
Thank you.
Thank you, Sushma ma'am and Hema ma'am, for this opportunity. Thank you all.
Thank you.
Thank you. Thank you so much.
Thank you.
Thank you, Vijayalakshmi ma'am. It was a great time with you.
Thank you, Mr. Srikanth, Amit, and the RX Events Mahima for the seamless coordination. Mahima, could you please provide the attendance list as of the previous session also?
Yes, ma'am. I'll just mail it to you.
Okay. Thank you so much.
Thank you, Srikanth and RX Events. Thank you so much. Thanks, Hema.
Thank you, ma'am.